right, good morning. All right, I want to welcome everyone to this amazing celebration of Dr. Craig Miller's phenomenal career. It is indeed a special moment today to honor this gentleman who has had such a great impact on so many aspects of clinical cardiac surgery, research, education, and leadership. And we have those themes peppered throughout today's discussions. Craig and I spent many hours together in his office working on how to celebrate today. And we wanted to focus on not Craig, but on you, the graduates of Stanford Cardiothoracic surgery. And that's who we've asked to speak. So I want to first start with just a couple housekeeping items. I want to start by first thanking our organizers, Maggie, Luke, Deb, and Jason. Thank you so much for your immense, tireless work on organizing this event. I'm sure it was not easy, especially working directly with Dr. Miller on some of these items. So thank you very much. We have several sessions today focused on things that Dr. Miller was involved in. Leadership. That's not a real photo, right? Okay. Leadership, aortic valve, thoracic aorta, mitral, and multi-valve. And I'm not going to spend much time introducing the speakers. We have everyone's bios in here, so we'll save the time for discussion. We wanted to start with the leadership session, and for that, I wanted to start this entire day off with AATS past president, Dr. Vaughn Starnes.
Well, it's obviously an honor to be here and recognize such a great role model that we've all had in academia. Craig, it's been wonderful to be part of your career and learn from you. So I was asked to speak about leadership, what I'd learned from the ATS. And speaking before this audience, it's sort of humbling. But anyway, sometimes we are so busy, we don't take time to pause and stop doing rather than reflect on what we've done in the past. So I'm going to spend the next sort of 10 minutes with you to look at reflections of what I thought happened during my year as president of the AATS. So I'm going to break these down in some lessons that I thought I had learned as I reflected back. I think leaders need to be adaptable. As mentioned above, things don't always go according to a perceived script. We need to adapt to changes and respond accordingly to what comes our way. When I first began my term, I was obviously excited. I was going to do a lot of great things. I was going to be changing the organization. We're going to have a lot of new programs. But things changed, and COVID was here, and we had issues. We had to change from a format of in-person meetings to a format of a Zoom meeting. So you're looking at a guy that barely crawled out of a cave when it came to technology, and then suddenly this was thrust on me to do Zoom meetings. But one of the things that I found that was very important during that period of time is to have people who believed in your leadership and the importance of followers and held them buy into what you're trying to accomplish. And this is comes about with what I call the hidden curriculum. You can often tell people what you want them to do, but they're observing what you do. And I think that's the most important lesson I learned about being adaptable. Lesson 2, I think we need to know ourselves and understand our leadership style. There's many inventories about leading and being a leader. But I think, one of the things that you have to understand is, what kind of leader are you? Are you one that directs, you define the roles and tasks of the follower and supervises them closely? Or are you a coaching leader who defines the roles and tasks but seeks suggestions from your person you're trying to coach up? Or are you a supporting leader? Leaders pass day-to-day decisions on to their followers, and then they coach them through it. Or are you a delegator? You give them a task, give them an opportunity to go and lead and learn from their own mistakes. The control is with the follower. Well, this is a Maslow pyramid that I think we are somewhat familiar with. And this is sort of the stages of people looking at the needs model hierarchy. We all want to obtain self-actualization and self-esteem. But when things get tough, you start falling down the pyramid and you look at safety and security and basic physiologic needs like food, water, shelter. And I guess during this period of time of COVID, we were all pivoting to the basic needs of ourselves, our family, our community. It reminds me of the Craig Smith writings that came out during this period of time where we're all really looking at each other and seeing how we're going to get through the next day. So things fell from, I'm going to build a great organization to how we're going to get through this. It was time to pivot. So leadership is also about how do you motivate others? How do you keep people engaged? How do you keep them believing in your goals? And I like this quote, and I sort of keep it in my office. Leadership is not the private reserve of a few charismatic men and women. It's a process that ordinary people use when they are bringing forth the best in others and themselves. So I believe what leaders really do is they develop others. And I think these are three things that I think are important when you're coaching or you're trying to develop other people. They need their own autonomy. They need their ability to develop their own competence. They need to get through their own processes and learn how to complete those. And they want to have a project that is purposeful and it can help others. And during this period of time, we all thought about having goals, achieving higher goals during this period of time, but it all came back to basic needs. How can we help others? How can we get through the day? And there was nothing more important during this period of time than it was the frontline healthcare workers that we all looked at every day to get us through the next day. So I think as we motivate others, we look at relatedness. How do we make sure that what we're doing today has a purpose and it will get us through? So I'd just like to conclude with some of the things that I felt like that came out of my reflection of what I learned as being the AAT president. I think these 10 things are true of most leaders. They're adaptable. They can pivot when needed. They teach and role model best practices. They adopt different leadership approaches depending on the situation. They recognize their leadership style. They understand the importance of followership. They reflect on and learn from the past. They understand the needs of their followers. They develop other leaders, and they create a culture that promotes autonomy, mastery, and relatedness and belonging. Thank you.
So I'd like to welcome to the stage Dr. Bobby Robbins, past president of University of Arizona.
Well, good morning, everyone. It's great to see so many familiar faces and to be back home with this group. I thought I had 5 minutes. I never use this, but I put a timer because, the Mark Twain thing, it's a lot easier to give a longer presentation than a short one. So I promised Joe that I would stay on time, and of course, I'm not going to use any slides. I'm not really sure what I can tell you about what I've learned about being a university president. I, of course, will come back to Craig and talk about him. But I think, we all of us who are the F1 and even the F2 generation of Dr. Shumway wouldn't be here if Dr. Shumway hadn't taken a chance on all of us. And certainly, I don't know if Bruce is here, but Bruce took a chance on me and allowed me to come back. So I would be eternally grateful to both of them and all of you. Is not enough time to mention everyone. I think that, there are a couple of things I did learn. Being a university president, you have many stakeholders and many people to deal with. Number one, there's the students. Number two, there's the faculty. Number three, the staff, because you can't have a great university without great faculty and staff that support that faculty. All these things, by the way, I learned right here, which is I often get in trouble about saying that this is the greatest university in the world, but I believe it is for many reasons, and certainly this department. So a lot of these things I learned right here from all the mentors that we all share. And then there are the donors, the alumni, the people who love the university. They're city, county, state, and federal officials, and so you have to pay attention and keep all of those people happy at the same time. And that's like trying to keep. We were talking last night about keeping room 1 turned over in time after Craig was finishing a case up at 6 in the morning, and then Vaughn had 3 cases to follow, and it just never stopped. So a lot of this, of course, you have big teams, as you all are leaders and go out and you lead big teams at your respective institutions, but it's always great to come back here to get replenished and renewed and reactivated. I get a chance to be here for the next year or so, and until I take off on my next crazy journey, whatever that may be, being at the Hoover. So I was talking to Mike Fowler about where are the conferences. It looks like they've all gone online. As Vaughn was talking about all the meetings that we had during COVID. I took a little different tack at Arizona. It was somewhat controversial. We kept the university open. The faculty, of course, didn't like that, but students did, and particularly the parents or whoever was paying for the students really liked that their students got to go to class, and we kept the thing open. And we took a different approach that, we were going to understand and have a lot of testing and keep people safe. And I'm happy to say there was no hospitalization. We've got 75,000 students and 20,000 employees, not one hospitalization. There was one patient with sickle cell anemia who got COVID, and we put her in the hospital overnight for observation. Other than that, we kept the university going. I will say, in reflecting on what I think about what we do as universities, there are many things that make it into the press. And I was talking to Robbin Cohen, who had this great video he was going to show, but I guess he got censored. So I told Joe, I will try not to do anything that's being videotaped to embarrass the department or the university or myself. But there are 3 things. One, we help our students realize their hopes and dreams. Sounds trite, but it's what we do. We help them realize their hopes and dreams, so hopefully they can go out and make society better. We discover fundamental new knowledge, and we translate that new knowledge into things that will help advance humanity. Now, Craig and I probably differ a little bit on and I stopped short of saying commercializable products, because we may differ a little bit on that topic. But I do think it's important to commercialize things, and certainly tech transfer. Stanford's been a haven for that over the years. When I got to Arizona, we had only had an active tech transfer office for 3 years. Think about that. Stanford, has been the maven and bellwether for that activity. And so it's really important to do the fundamental discovery, but then translate it into things that can help everyday people, applicable research. Oftentimes, one of the great things at Arizona is our space program, and we just spent $2 billion of money on the OSIRIS-REx project to go 300 million miles up there and land a spacecraft on an asteroid that's the diameter of the height of the Empire State Building to get a sample. And I thought we were going to land and get a bunch of rocks and bring them back. We were on the surface, or they were on the surface, for 6.7 seconds, and got 355 cc's of asteroid dust. That's the size of a Coke, 12 ounces, 355 cc's. And we brought it back, and it was a big, landing, and it hit within, 10 feet diameter of where it was supposed to land in the Utah desert, and everything was really excited. But that's $2 billion. Now, what do we learn? The thing I learned about astronomers, I always said they're even more expensive than than cardiac surgeons or football coaches, because they have to have these big things, this equipment. We're building the giant Magellan telescope down in the mountains of Chile, and that's $4 or $5 billion. But they care only about two things. One, how did our universe start? And two, is there other life out there in the universe? So, yeah, spending way too much time here. I better wrap it up. I think the final thing that universities do is serve their communities. And not so much for privates like Stanford, but for a big land grant public AAU university like the University of Arizona. We had cooperative extension offices in every county, and we served the community. It was part of our responsibility as a state land grant university. And I think that's true for every university. I'm enthusiastic about the future of universities. When I started thinking about doing this kind of work, I called Bill Brody up. I don't know if Bill is here. I know he's a trustee, so I have to be really careful now. But I said, Bill, they're calling me back at Ole Miss and said they want me to be a candidate to be the president there, and I'm not qualified to do that. What does a university president do anyway? And he said, you live in a big house and you go around and beg for money. And that's what I've done for the last 8 years, and hope to do that again very soon. I think it is true. And I don't know if Mike Dake made it. By the way, Steve Osley sends his regards. I don't know if he called you, but he wanted to be here. And I know Mike's going to be here. But of course, in true form, Mike is going to leave this afternoon because he has 4 seats on the floor for the Duke Arizona basketball game in Tucson. So please give him a pass on that. But, Bill was right about that. And I think when you get excited and want to inspire others about supporting a university, fundraising is actually fun. And people really like that you come out and you talk to them and tell them about ideas that will advance the university. But 80% of the time I can confirm is spent on jocks and docs. And I had a 5.5 year, a month into my tenure, I got a phone call, 7 o'clock in the morning, getting out of the shower, was enthusiastic. And the voice said, "Is this Dr. Robbins?" I said, "Yes, it is." And he said, "Well, this is a special agent in charge of the FBI in Arizona. Just wanted to let you know we just arrested one of your assistant basketball coaches." And I said, "Well, what am I supposed to do now? I missed that class in medical school." He said, "Call your general counsel. Have a good day. Click." And for 5.5 years, we battled the NCAA banner. Conrad and I were talking a little last night. The way we got Banner to buy our hospital is somewhat controversial, but I dealt with that all day, every day. And then the final thing is, if you're a really bad president, when you go to hell, you get not 1 but 2 medical schools. So we had 2 medical schools fully accredited in Tucson and Phoenix, and so I guess I've been living hell on earth for the last 8 years. But Joe, thank you very much for inviting me to come and give a few reflections, and for the job you've done leading the department. And Craig, I didn't get a chance to say enough about you because I was running out of time, and I knew I would. But I would just tell you how that meeting that you had with me in New York City at Dr. Mom's AATS reception and introduced me to Dr. Shumway, and he looked over at my name tag and he said, "You're going to NIH. Some of our guys went there. Stinson went." And about 3 weeks later, I got the letter that changed my life. So I want to say from my heart, I love you, man. And thank you for everything. Thank you.
Great. Well, Conrad was just alluded to, another graduate of the program who is now a very senior leader in health system at Sutter. So we'd like to introduce Conrad. There he is. Come on up, Conrad.
Good morning, everybody. This is an incredible honor to be able to participate in this. And I want to start by telling you a story about when I was getting ready to apply for residency training. I went to see Dr. Miller. I'll explain why I went to see Dr. Miller in a moment. Made an appointment and walked into his office. And of course, he's very busy. And he said, "Well, I know why you're here, and here's what I'm going to tell you. If I were you, I get rid of these notions of going into cardiac surgery. And I'd aspire to be a frontier general surgeon taking care of everybody from the neonate to the grandpa. Well, needless to say, I was pretty shocked, but I was even more shocked when Dr. Stinson walked into the office looking for a VHS tape of an echo. Dr. Miller said, "Ed, I don't know if you know this young man, it's Conrad Vial. I just told him that he ought to be a frontier general surgeon, go out and take care of everybody from the neonate to the grandpa." Dr. Stinson looked up at me, didn't know me from a hole in the wall, looked up at me and had a very intense stare that he held for just a few seconds because he was in a hurry as well. And it was written all over his face, though. He's like, well, you know, you did ask for this, and this is the way it is, and good luck to you. And he walked away. Well, needless to say, I didn't take Dr. Miller's advice, and I'm grateful every day that I didn't. And I didn't take his advice because of him. He had everything to do with it, because he infected me as a medical student. He gave me an opportunity to be in his lab and be a very, very small part of the team. But I learned 3 really important things that have inspired everything I've tried to do and everything I've tried to be since that time, in that incredibly intense set of experiences that I had in his lab. And I want you to know how grateful I am for them. I want you to know that I've always hoped that I would be worthy for the fortune that I had to be in that lab and work with those folks, many of whom are here. Again, in a very small capacity. I learned 3 things there, and they do relate to health systems and leading health systems. One is that what I experienced in Dr. Miller's lab, and in observing him especially, was the animation of a reflection that Theodore Roosevelt had many, many years ago, obviously, said that life's greatest prize is to gain the opportunity to work hard at something worth working hard for. That's the first thing I learned in the lab. Second thing I learned is that we live in a society and in a culture that promotes production, sometimes production at all costs. But there's a bigger category, a more noble category, and it's called performance. And if you are producing but not performing, you're undercutting yourself and you're undercutting your colleagues. And the third thing I learned is that what we do matters. And if you want to be an impact player in that space, you have to recognize that it is a team sport, that the great personage theory of either leadership or even the surgeon is a bunch of bunk. But it's about building and nurturing a team around you, because that's the only way you can move beyond production to performance. And it's the only way that you can, and this is where we come on to health systems, it's the only way that you have an opportunity to force multiply, to amplify your impact. And what I saw in Dr. Miller was somebody who had chosen how he could work in the very intimate space of taking care of individual human beings and their families, and being trusted by them in moments of incredible vulnerability. But at the same time, generate beyond intimacy a scale level impact. And everybody here today, and everybody who's here represents, because they are legion behind us, who've been impacted by the lives of Dr. Miller's work, represent that force multiplication. He did it through leading in education. He did it through leading in training. He did it through leading in research. Everybody's got an opportunity to figure out how they can force multiply in the big and the small. And I think leading health systems, contributing to the leadership of health systems is another way to do that. But the principle for me was inspired by what I had an opportunity to be a part of at a very early formative stage in my own development, and what I had the great fortune to be able to continue to be associated with through the rest of my training in general surgery and cardiothoracic surgery. Now, to bring it to healthcare systems, very briefly, there's lots of ways that we could talk about how healthcare systems are part of the problem, but let's talk about how they can be part of the solution. And they can be part of the solution by taking inspiration from the very same principles and the lessons that I talked about, that I learned about in Dr. Miller's lab as a medical student. We are facing a major calamity in this country. Healthcare resources are strained, but you know what? Healthcare talent, healthcare workforce availability and engagement is strained. And that includes all aspects of healthcare, up to and including physicians, and yes, even cardiac surgeons, who are actually the most stressed and the most low in supply relative to need in the country among surgical specialists. University systems are taxed in ways that you all know, many of you much more than I do. And their bandwidth to be able to stand in the breach by themselves is taxed. And in the 6th largest standalone economy of the country, that the state of the world, that the state of California would be, and in Northern California specifically, where we have all of the power and the might of Silicon Valley concentrated, we have primary care deserts. We've got entire communities, particularly in rural parts of our states, that don't have enough physicians today, and the problem isn't getting better, it's getting worse. So from my perspective, the opportunity is for us to spend less time competing around who's the more noble citizen of the republic, and more time collaborating where it makes sense to collaborate, contributing, building strength upon strength. A system like Sutter Health is never going to be, and should not try to be, what this institution is. But it ought to take its place in trying to contribute to closing a gap that, if we don't close as a society, we're going to be in even more trouble than we are today. And we've just come out of a pandemic that demonstrated it. The collaboration goes beyond people and talent development, although that is our most precious resource. And it goes beyond a system like Sutter Health wanting to train and ultimately retain talent that keeps the system vibrant and contributing. It goes to the fact that as healthcare systems serving the same community with large zones of overlap, we have not only an opportunity, we have a mandate to collaborate in ways that open up opportunities for people to have care, not just because we're producing more and better physicians together, but because we're collaborating, not just on producing the horses, but the riders as well. And we bet on the riders. But the riders do need horses. And this is something that I've been involved with and that I'm really excited about. Stanford and Sutter are combining to make a major investment in comprehensive cancer care, bringing it to a sector of the core Bay Area, which you would not imagine is an oncologic desert, but in many ways it is. People have to travel far away for baseline. And let me tell you, let me bring it home for you. My wife and I have 3 sons. We've been blessed with 3 sons. My youngest was diagnosed with acute myeloid leukemia 6 weeks ago. Yesterday, he was discharged from this hospital after 6 weeks of induction chemotherapy with the best care that anybody can get and the best shot at survival and healing that anybody can get. And I'm eternally grateful to my alma mater for that. But here's the question I have for all of us. What about, my son's name is Giovanni, what about all the Giovannis that don't have a dad who's in the healthcare system? Does the system work for them? Is there enough there for them? And the answer is no, but the opportunity is for us to combine our talents in ways that frankly respect 100% the principles that I learned in Dr. Miller's lab, to guarantee that opportunity for everybody. So I appreciate being included, Joe, in this. And Dr. Miller, thank you.
Another one of our graduates, Jim Fann, has held a national leadership role in the ABTS, and we wanted to hear some lessons from him about the organization that accredits our specialty.
So for the American Board of Thoracic Surgery educational initiatives, the leadership lessons are different than what we think of in academia and healthcare organizations. As background, CT surgery training, there are three legs of the educational stool. The ACGME, or Accreditation Council for Graduate Medical Education, is a independent body that oversees and accredits residency programs. The Thoracic Surgery Directors Association is composed of program directors and identifies and supports educational needs and residencies. And the American Board of Thoracic Surgery certifies the individual after completion of training in an ACGME approved program. Understand that there are constant communication amongst these entities. So the ABTS serves the public by promoting excellence in practice through rigorous evaluation and examination, providing leadership and education, ensuring high standards for professionalism, lifelong learning, and certification. As a trainee, often your first contact with the ABTS is a case list, which is one proxy of competence. As you can see, there's general thoracic surgery track, cardiothoracic surgery track, both of which we have here at Stanford. And also there's a new track that's started in 2022, which is a cardiac pathway, which requires more cardiac and fewer thoracic cases with an emphasis on structural heart disease. After completing residency, your next contact with the ABTS is ultimately reflected here, the results of the board exam. The pass rates have varied somewhat over the years. For 2023, the overall pass rate for the written exam was 82%. And for the corresponding overall pass rate for the oral exam was 73%. So ABTS comprises the executive director. Former executive director is actually here today, Bill Baumgartner, the board chair, exam chair, and 18 directors, plus or minus, from various organizations, 4 from the AATS, 4 from the Society of Thoracic Surgeons, 2 from the TSDA, and 1 from the American Board of Surgery, American College of Surgeons, American Surgical Association, and Congenital Heart Surgeons Society. As director, your value is largely predicated on your commitment to the elements of certification, specifically building the exams and participating in oral exams. Current methods of assessment relate to knowledge and decision-making, perhaps skills assessment in the future. Organizational and diplomat issues such as finance, credentialing, and professionalism rely on your experience and expertise as surgeon educator. Here are some updates from the board. Congenital questions will continue to be on the written exam, but will no longer be on the oral exam. The key features exam questions focus on decision-making with write-in responses are being trialed as part of the written exam. Maintenance of certification is being modified and CSATs has been suspended. Finally, documentation of professionalism will likely be required. These are some activities I've been involved in my path in formalized education, including the Joint Council, TSDA, initiatives at the AATS and STS, the journal, and ACGME milestones. Here, the leadership challenge revolves around collaboration or collaborative leadership. For formalized education, the business model is distinct from that in healthcare organizations. Educational products are often based on volunteerism and without a profit margin. The return on investment is not reflected in the typical business cycle. If you create an educational module, you won't know if it's of any value for many years, and any future benefit to education may not be directly attributed to your product. This limitation was the Achilles heel of the Joint Council and likely its failure to maintain traction as there is no clear ROI. Efforts in education require building relationships, specifically collaborative leadership, in contrast to top-down management. Since there are outstanding educators who are not recognized nationally, tapping into their inventiveness in establishing relationships at various levels are critical. My early work with Rick Fines at the ABTS led to the founding of Boot Camp, which in turn became a means for me to work with those interested in education. It was also the relationship with young surgeon educators that resulted in the thoracic surgical curriculum and the simulation handbook, both on the TSDA website. Central to collaborative leadership is identifying those who are committed to education and promoting their accomplishments. In short, collaborative leadership requires flexibility, as leaders must adapt to the needs of the group, employing collective intelligence and fostering shared responsibility. So that's it on formalized education, ABTS. Now I'd like to ask for indulgence as I share some thoughts about Craig, its impact. Pause, you who read this, and think for a moment of a long chain of iron or gold, of thorns or flowers that would never have bound you before the formation of the first link on one memorable day. Dickens highlights how a single moment could set in motion the chain of events that shape the course of your life. As I describe my path, I urge you to reflect on the DCM link in your life. The link with July 25, 1986. As a second-year general surgery resident struggling to find my footing on my second rotation on cardiac, I ran into Craig in North ICU. Craig, just shy of 40 years of age and already of international renown, offered me a position in his lab. The lab resident with whom I was to overlap with George Saris, followed by Kwok Yun, sitting here with our technician, Cindy Handon. To this day, there's a bond among those in the Merrill lab, a bond forged by Craig's ethos. You worked with him on a quest, often manifested by ad hoc lab meetings at 2 a.m. on Thursdays after he spent the previous 16 hours in the OR. Craig taught us you should always be curious and aspire, lest you become a spectator. This is from the American Heart Association meeting circa 1994. Miller Lab residents, including undergraduate, graduate, international scholars, many of whom are here today, total more than 50 accomplished individuals. The Miller Lab was a link to Stanford cardiovascular training. After a meeting with Dr. Shumway, I was penciled in the book that Adina kept in the drawer. Because my final year in general surgery was 1992, and since there were already 2 names on the list to start cardiac that year, Adina asked if I would do a year of vascular surgery with Craig and Scott before starting cardiac. Of course I would. The connection to Craig is inseparable, much like the many aspen trees I make of Pando, which covers over 106 acres weighing over 6,000 tons. All these trees are in fact shoots with a common root. Throughout the remainder of your training and well into your faculty years, you continue to take on new DCM writing assignments. Nearly 4 decades after my time in the lab, Craig and I recently updated our mitral valve chapter in the textbook Cardiac Surgery in the Adult that we originally submitted to Hank Edmonds in 1995. As I was completing my training. Stanford Cardiovascular Surgery is Dr. Shumway's house, and education is paramount. You'll hear this mentioned many times today that Craig is a quintessential educator. Craig's dedication to surgical education anchors his legacy. As residents, we waited and practiced surgical maneuvers so that we could do it when Craig gave us a chance to be, quote, on the wire in the OR. Craig always gave you the first shot, open the aorta and place the stitch. Be prepared and not waste such opportunities. Practice outside the OR is foundational to the area or the idea of simulation-based learning. When I joined Tom at the VA, our mission was to teach the Stanford way. The VA business plan was premised on mine being 50% vascular surgery, hence another link. In 1999, it was clear that practicing surgical skills can be formalized by using simple devices or simulators. This project led to work with the TSDA Joint Council on ABTS. But back to the writing. Most of you know that there's writing and there's DCM writing. Reams of DCM marked up manuscripts may be more critical and discriminate, essential to working on educational initiatives. No doubt interactions with Craig also made me a better examiner. My path at Stanford has been defined by many connections, the most important of which is the link of gold with Craig in the Merrill lab. Muriel Strode best summed up Craig's career. Go where there's no path, leave a trail. Thank you, Craig, for your support in creating the path. And thank you all for the chance to share my thoughts.
Okay, well, I'm going to take a moment to provide an update on our department. And I wanted to start with this slide because I think if you read this article, it really summarizes all of Craig's success in the things we've talked about: leadership, patient care, research, and education. And so I decided to build a small talk around those themes. So, but let's go back. Let's go back a little bit, all the way to Dr. Shumway talking about the residents.
And that's the best thing you can possibly do, is to provide an opportunity for the other people to come by and to make their suggestions and their improvements. And then you see we're learning too, because every resident that comes through the program will change things, maybe just a little bit. Sometimes it's not as good, but most of the time it's better. So we keep refining our methods all the time because of these bright young guys that are coming through and having a chance to make these contributions.
So I think that sums up the overall theme of today's celebration. Let's talk a little bit about department faculty. This is our front page of our website, and our department's grown. We now have 50 faculty, and that's across 3 major divisions. Our structure is now with Frank Hanley as our former division chief. Now Mike Ma is our division chief. Frank Hanley still serves as the service line head. Joe Schrager is the thoracic division chief. Mike Fishbein serves as our overall residency program director. Leah Backus serves as the director of faculty development, and Jason Irwin, who's here, serves as the director of finance and administration. And then as our cardiac division has grown significantly, we've now divided into 4 distinct sections with leadership: Mike Fishbein of the aortic section, Jack Boyd, coronary valves, Elon Burton, our affiliate section, and Will Hiesinger, transplant and MCS. So section heads. One thing that I'm really proud of is every year we take a photograph down in the lobby of Falk with all of our women faculty. And when we started, we had 0 faculty that were women, and we've made an active effort to broaden our overall group. And seen here are our 11 women faculty across cardiac, thoracic, and congenital. And we just signed number 12 and have an offer out to number 13. So we're making progress here in an area that has really significantly been underrepresented over the years. And on the very end there is Pat Kasinpila, who we all know, and we're going to hear so much more about and from. So the other thing we've done is expand our visiting professorships. So we had this Shumway, we've always had the Shumway, which classically has invited prior graduates of the program. But since that time, we've been able to expand significantly and build one for Bruce Wright, one to honor Larry Cohen, one to honor Jim Mark, recently one to honor Ed Stinson. Very recently, we built one for Phil Oyer, who's here, and the inaugural Oyer will be in January. And then we are in the process of building the D. Craig Miller Visiting Professorship. And I've invited, and Lars Svensson has accepted the invitation to be our inaugural D. Craig Miller Visiting Professor. So typically, this is the point, since Dr. Robbins talked about donors, this is the point where I would go around and ask all of you to donate to help support the D. Craig Miller Visiting Professorship. And I'm not going to do that. We're going to find a way to do that. But instead, I would ask you if this is a good time of the year to consider giving to honor Craig Miller. It would be wonderful for you to consider donating to the AATS instead of donating to Stanford. This would have, I think, a greater, broader impact across our entire specialty. And a couple of years ago, I proposed creating this Honor Your Mentors program, and Dr. Miller kicked and screamed and fought against me on this, but eventually relented because we really showed that this program, which will be built around funding hypothesis-driven research, really something that is underfunded throughout our specialty and again, reflects his extraordinary career. So there he is on the AATS Foundation page, and I welcome all of you to consider going to this page and making a gift to the AATS to honor Dr. Miller. We're very fortunate to have Dr. Abe DeAnda be on the steering committee to help me together with Mark Moon, Mike Fishbein, Joe Caselli, and David Adams. And we will be, if not speaking with you directly, we'll be calling all of you to help sponsor this program. Thank you. Okay, let's move on to clinical care. So there we are on the peninsula. And what we've been able to do over the years is organize multiple satellites, which range from wholly owned facilities to PSAs. And these exist all the way up in Oregon, across most of California, and even into Hawaii. In terms of the specific areas, well, we always start with heart and lung failure because this program, this department is so storied in its contributions to transplantation. Dr. Shumway and Dr. Stinson's first heart transplant, Dr. Wright's first heart-lung transplant, Dr. Starnes' first lobar lung transplant, Dr. Oyer's first successful LVAD bridge to transplantation. I mean, that sums up an entire arena of transplantation and MCS and all the massive contributions that have been made by Stanford graduates and Stanford faculty. Well, we've tried to do a little bit there. So during the middle of COVID, we were fortunate enough to perform the first multi-organ transplant for a COVID patient, one that had been on ECMO for 3 months that we prehabbed and were able to successfully multi-organ transplant and send home. We also more recently performed a beating heart transplant. So I'm going to play this video for you. This is a heart that's brought back on the OCS system. And instead of stopping the heart as is protocol, we decided to place a cardioplegic cannula and deliver warm blood down the root, disconnect the heart. The heart came back beating. It continues to beat. And now we're sewing it in while it's beating. So a slight change to the Shumway-Lauer transplant technique. But as a credit to our education program, the blue gloves are our chief resident sewing this in. So the very first time we tried this operation, we have our resident sewing in this entire heart. And that resident is Pat Kasinpila. Thank you, Pat, for doing a good job. This is actually taken off and is being used at 15 centers around the nation right now. And Dr. Brandon Gunther is leading a multi-center study on this now. In thoracic aorta, we always show this slide. Unless you're in Houston, anywhere else in the world, you talk about type A and type B dissections. And this is where it came from. Well, we're continuing to make some innovations here. One of the things that has been done most recently is a study that changed the 2022 ACC/AHA guidelines. This basically built upon a study performed here by one of the lab residents, changed the recommendation to transfer patients with type A dissections to a high volume aortic center. So that's now codified in the guidelines based upon research work done here at Stanford. What else are we doing? Well, Mike Fishbein has been pushing the envelope in patients with connective tissue disorders. In Loeys-Dietz patients, he has developed what I would call a not bench to bedside, but really OR to bench to OR pathway, where basically they found in completely normal sized arches of patients with Loeys-Dietz, significant abnormalities in the cellular biology consistent with the disease. And so Mike Fishbein now has been taking patients who he's operating on for a valve-sparing root replacement and doing prophylactic total arch replacement. It's pretty extreme. And he's been doing that and doing that very successfully, publishing on that. And in fact, he's in the operating room right now. We've named OR 15 after him. And he spends a lot of time in that operating room. And, I just want to say that Mike Fishbein has been an incredible partner to me in working on this program. I don't have a linkage to Stanford, but I have Mike Fishbein. And he's at my side every single day. And Mike Fishbein is the link directly back to Dr. Shumway and everything that this program is so renowned for. And so we make all decisions jointly. And I can't thank him enough for all of his tireless efforts to advance the department. Valvular reconstruction. There's something famous here too. So Dr. Tom Burden and Mariel Pampili, back in 1995, took the first heart port instruments and went to Malaysia and did the world's first heart port mini mitral operation. These are the actual instruments. And there's Tom. He looks a little bit younger, but we'll be able to talk with Tom later during the break. And so based upon that legacy, we're now doing minimally invasive mitral as the sort of standard approach. And I wanted to just highlight something here, which is, again, around the theme of education in our residents. This is our marketing brochure. This is a brochure that we give to patients, to the referring doctors. And what you'll see here is I'm there and I'm not doing anything. My hands are one is not just resting there and one's down here. And that's our chief resident performing the operation, performing a minimally invasive mitral repair operation. And that resident is J.W. MacArthur, who you'll hear from later. He's also in the operating room right now. So that's the approach. More recently, we've had the privilege of being cited by the American Heart Association and the Mitral Foundation as one of the centers of excellence in the nation for complex mitral valve repair. In other areas of valvular reconstruction, we're doing a lot of valve-sparing aortic root replacements. Dr. Miller pioneered the SMOD, and we'll hear more about that during the discussion. We're doing a lot of Ross operations now. We like to do this with the Starnes technique. On coronaries, we're pushing the envelope with minimally invasive robotic mid-cab. Dr. Elon Burton and Dr. Jack Boyd are leading that program. That's what that looks like. Arrhythmia surgery, we had the distinct privilege of recruiting back in 2015 a long-time trainee of Ralph Damiano's at WashU. Anson Lee spent 13 years at WashU with Ralph Damiano and in that lab, and came here and built our arrhythmia surgery program. And now, together with Jim Longoria, they have one of the highest volume hybrid AFib ablation programs in the nation. In pediatrics, we all know about Dr. Frank Hanley inventing this particular operation that has basically become the largest program in the world for complex pulmonary artery reconstruction. Mike Ma's written this up under Mike's leadership. The VAD Center has become the highest volume VAD center in the nation, pediatric VAD center, and also often is the highest volume pediatric heart transplant program in the nation. In thoracic, under Joe Schrager's leadership, they've obtained National Comprehensive Cancer Network designation. They've expanded robotics. They do everything with robotics now. And they've also built a program, which we haven't named yet. I just called it the Giant Thoracic Tumor Program. I have a video here. I hope this plays. Yeah. So this is the thoracic surgeon taking out a tumor. Yeah. Yeah. So if you have a good name for this program, I'd be very interested. There's one of the specimens. There's another specimen. They're all very proud of this program. And then finally, because we are Stanford, of course, we're doing basic science translational work that goes into the clinic. So I call it cellular or molecular adjunctive therapy. And this is stem cell delivery during LVAD implantation. So what are some quantitative results? So this is our cardiac surgery volume growth over the last several years. So this is major cardiac cases over the last decade. Slight dip during COVID. This is overall transplantation going all the way back to Dr. Shumway's very first transplant in 1968. And you can see the growth across adult and pediatric. This is mitral valve repair operations over the last decade. Valve sparing aortic root replacements. And in case there's any concern that this is all about volume and not about quality, our external metrics, external report card from Vizient, which all of you are very familiar with, has us, this is the most recent quarterly update. And if you look back for the most recent year, our cardiac surgery 1 year observed to expected mortality is 0.43. So very statistically significantly less than expected. This is how we've done on US News and World Report. Not that we put a lot of weight into this. I think most centers and programs are moving away from the value and the validity of this ranking system, but we've paid attention. We fluctuated around 8 or 9 the last few years. Pulmonology and lung surgery have climbed up to number 7 just most recently. Moving on to research, I mentioned this already. This is the publication by AJ Pedroza and Mike Fishbein, basically looking at understanding the cell biology behind connective tissue disorders and the impact on translational relevance. We have a broad range of research in our department. We send people up to the Linear Accelerator, SLAC, to study novel peptides that we've built. So they're going up there and they're bombarding subatomic particles along this 1.75 mile long building. This is one of the students who got his badge. Doesn't look very happy because I think he's worried about getting irradiated up there. This is some mechanical engineering work comparing various configurations of valve-sparing aortic root replacement. This is Anson Lee's work. This is very interesting. This is a fabric that can be wrapped around the heart that has 256 EKG leads. So instead of an external EKG, you get an internal EKG that you can put on the heart and map the entire atrium and find the exact foci of atrial dysrhythmias. Jack Boyd's working on computational flow dynamics modeling of coronary artery bypass grafts, and also has a startup on an external vein graft stent. Tony's working on a human Langendorf model. So taking explants from heart transplants, bringing them back to the lab and reanimating them with human donor blood, and then studying them electrophysiologically in Anson Lee's lab. And we're obviously very interested in this from a mechanics point of view. While we are in Silicon Valley, so there is a lot of artificial intelligence work being done here. One good example is Will Hiesinger's laboratory. He's been partnering with the Stanford supercomputer, which we've bought several nodes at. So now we are timeshare owners of the Stanford supercomputer, and we go to the top of the list whenever we have a project for the Stanford supercomputer. But Will's gone even beyond and is working with Google and other big Silicon Valley tech companies to study preoperative imaging and trying to predict outcomes with, at first, LVAD implantation, but then other operations. And Will has been able to obtain an NIH R1 based upon this project. Joe Schrager has continued to do his work on the JAK-STAT pathway and diaphragmatic dysfunction in ventilator-associated dysfunction. And also in thoracic, Natalie Louie has been working on robotic tracheal surgery. So that's going to be very exciting. And then this is a fun set of slides in here. Brandon Gunther, who did a lot of work when he was a resident on xenotransplantation, has come up with a whole sort of new idea about how to use organ perfusion systems and xenotransplantation. So instead of just having an isolated circuit where you try to rehab the lungs in preparation for transplantation, he's trying to think about, could you take specific animal organs and xeno rehab the lungs? So basically developing essentially a cross circulation system with an animal and having the animal's physiologic function, liver, kidneys, etc., try to improve the function of the lungs. Mike Ma is doing some very innovative work in mechanical engineering in neonates, univentricular physiology, studying the valves, but also trying to find ways to make the univentricle grow, the other ventricle, so that the children can be taken down a biventricular pathway. And then finally, Nan Huang has been doing some basic cellular biology and has sent her work up into the International Space Station. So this is a tissue engineered muscle in microgravity. And there's some of her work being sent up, and there she is for the launch of her cardinal muscle. So these are just some of the journals that we've been able to have our residents publish in. And this is some quantitative results on research. So this is overall department publications from 2010 to 2022. And remember the little blip downwards in clinical productivity during COVID, the residents and the attendings just started doing academic work. So we got a nice little boost there. And this is something we're really proud of. So major federal grants, so defined as R01, U01, P01, or VA merit over the last decade. We just secured our 17th active NIH grant. And those are all the PIs that are listed there. Mike Ma is the most recent NIH R01 recipient. So then finally, and most importantly here, the education. We heard a bit about programs, and I'm going to show a little bit about people and what they get to do. So this is AJ Pedroza, who I showed authored that paper. This is AJ as a PGY2. He's 2 years out of medical school. I remember in general surgery, I was putting in Hickman's, and AJ standing on the right side of the table there, and he's sewing in an aortic root replacement, Bentall, and a mitral valve repair. And he did the entire operation. And what's most important is that the patient was a cardiac anesthesiologist. Pat Kasinpila, we're going to hear a lot about her. Well, this is Pat as a PGY2, and she's doing a valve-sparing aortic root replacement, PGY2. These are real events, real dates, and this is her valve-sparing root replacement. Looks pretty good. That's why she'll be talking about that topic today. And then Yuanja Zhu, currently a PGY4, went out of the clinic as a PGY2 and spent 4 years in the bioengineering department getting a PhD in bioengineering. And that's her proudly wearing her Stanford engineering t-shirt. She developed some novel prostheses and then basically translated this into sheep and has been implanting and operating on sheep entirely by herself. So in education, this is the total number of ACGME approved residency slots. These are our latest residents who just showed up a couple months ago. So Elle from Yale, Sophia from Harvard MIT, Ben from Hopkins, Corbin from Hopkins, and Greg from Penn. And then perhaps most importantly, what do the residents do when they first get out of training? So this is J.W. MacArthur, his first 6 months. These are some of the cases that he did as an sole attending. Okay, so just look at that list. So valve sparing during a type A, heart liver en bloc transplant for Fontan, redo total arch, double lung transplant, the 1000th at Stanford, gastroepiploic cabbage, 4th time sternotomy, TAVR valve and valve. We'll hear a little bit more about that later. CCTGA, heart transplant, VSD, mid-cab. And then somehow he was dabbling in plastic surgery also. I'm not sure why he did this. So mental and latissimus dorsi, free flap, but he's doing a good job. And this is an example of the residency program that so many of you built over the many, many decades. And this is what Stanford has been able to produce in large part, Craig, thanks to you. So we want to thank you again for everything that you've done for our specialty and for Stanford Cardiothoracic Surgery. All right, great. Well, welcome back. I think we're going to continue having these sort of longer breaks so that people can catch up. That's probably the most fun part of this entire day. We're going to move on to the aortic valve session, and we're going to start with Robbin Cohen.
Thank you so much for the invitation. And Joe, congratulations on, I would echo what Bobby said about the program. I think Dr. Shumway would be so proud to see what you've done with it. It's hard to believe that it's been 35 years since this picture was taken on the last day of my residency. In fact, I'm now older than Dr. Shumway was when the picture was taken. But I can honestly say that for those of us who had the privilege of being at Stanford during the 80s, it was the time of our lives. Craig, you're sort of a young, wow, you were sort of a young faculty member at the time, and I have to say we were in awe of your talent and your courage. You know, sometimes to paraphrase Ken Kesey, Stanford was a bit of a cuckoo's nest at that time by virtue of some of the stories that were coming out. And you'd be proud to know that part of my presentation this morning was actually censored by Stanford. So I can't show all of it. But, you know, I have to say, I'm so grateful to you for so much that you did for my career, starting with the first coronary bypass operation that you took me through as a PGY2 at the VA so patiently. And when I think of the things that you did for me, that's one thing, but there are also some things that you did to me that I just haven't gotten over. Like the time that you talked me into putting that shock collar that you had gotten for your Great Pyrenees to keep them quiet, and after a couple of drinks made me bark. Or the, you know, Jim Fann talked about what an honor it was for him to do the vascular fellowship, but I remember you mentioning to me on the first day of my cardiac fellowship that I was also the vascular fellow. And then I remember working so hard to make you satisfied, you know, with my coronary anastomoses. And finally, one day you went, you know, I think you might be getting the hang of this. And then you made me switch hands. So it was really quite a time. And, you know, the other thing is, you know, we really like to dress up, you know, for the presidential gala at the Western, you know, here's Scott Mitchell in Armani, but only you would accessorize with Stetson and Smith & Wesson. So those were great times and so much fun to be here. I want to talk to a little bit today about some of the controversies surrounding TAVR. This is the adoption innovation curve, and I think we can all agree that we're sort of at the laggard phase where, you know, only the smallest and the programs that are behind are finally starting TAVR programs. And you can see that when there's such enthusiasm for disruptive technology, there's the threat of it reaching market share, maybe sometimes prematurely. And what we have to protect the patients in that sense is guidelines methodology with evidence, recommendations, consensus, and endorsement. And the guidelines for TAVR these days are actually pretty straightforward. If the patient's younger than 65 and has a life expectancy of greater than 20 years, it's SAVR. For the patients who are older, who may be candidates for both, it should be a heart team decision. And for the patients who are not candidates for surgery, those should undergo TAVR. So it's somewhat surprising. Well, actually, it's not surprising when you look at the national trends in TAVR in older age groups that there's a big upswing in TAVR and a downswing in SAVR. But one of the concerning things is that if you look at the left in patients under 65, you also see that similar trend. And one of the reasons is that there's actually a disconnect in the early trials between risk and age. The PARTNER 3 trial, which was the low risk trial, only less than 10% of those patients were under the age of 65. So low risk TAVR versus SAVR trials really have limited application to young patients. So one of my partners at Cedars, Mike Bowdish, has looked at this very carefully, and he looked at patients under 65 in California, New York, and New Jersey, which turns out to be about 20% of the population. And he found that in 2021, almost 55% of patients who needed aortic valve replacements got TAVR. And when he looked at the results of that, with all-cause mortality in matched patients, he found there was a 2 to 3-fold increase in the hazard of mortality with TAVR. And he came to the conclusion that there was a lack of concordance between clinical practice guidelines in patients under the age of 65. And he went on to ask these questions. What's the long-term durability of TAVR in young patients? What's the role of TAVR in patients with bicuspid valves? What strategies work best when the aortic valve prostheses fail? The answer to all of those is unknown. And then when you ask, is the heart team still working? Well, potentially not, if we're letting the above proceed without evidence. So let's look at some of the data. This is the NOTION trial, which looked at older patients with respect to structural valve deterioration. And if you look on the right, you can see that over time, even though there weren't a lot of patients left in the trial, patients at risk, there was actually a significant advantage to TAVR when it came to durability. So the question becomes, what will happen, and is any of this valid when you take young patients into consideration? When it comes to patients with bicuspid valves were excluded from the early randomized controlled trials. TAVR is currently approved for all risk levels, irrespective of anatomy. And the previous precautions regarding TAVR use in BAV have been removed from commercial labeling. So this is the NOTION 2 trial, which prospectively compared SAVR versus TAVR in patients between tricuspid and bicuspid valves in patients under the age of 75. And what they showed was that, with the exception of paravalvular regurgitation, which favored surgery in both groups, when it came to bicuspid valve, surgery was basically favored in all categories: death, stroke, or rehospitalization. Once again, in my opinion, under 75 or looking at the Medicare population isn't really a valid population to study bicuspid valves in. I think that we need to go way younger, so that data is not available. So if you look at the things that are available that we provide patients with regard to aortic valve replacement, and then you recommend them according to life expectancy versus surgical risk, you start with the Ross procedure and proceed to TAVR. We now have to add SAVR after TAVR, valve-in-valve post-SAVR or TAVR, and then SAVR after SAVR. And it turns out that the mortality associated with any operation after SAVR is exceedingly high, and that SAVR after TAVR carries a mortality of 14%. TAVR explant after SAVR requires aortic sinus or root reconstruction in almost a third of patients, and full roots in 14.3. Now, McCarr at Cedars' answer to this is that we can do valve-in-valve TAVRs with the same results that we do the first time. This is only 1-year data, but there were comparable procedure and 1-year outcomes with primary TAVR versus valve-in-valve TAVR. The Pittsburgh group compared redo SAVR with valve-in-valve TAVR, and they found that valve-in-valve TAVR and redo SAVR had the same mortality. It was about 2%. Patients who had redo SAVR had lower postoperative mean gradients, greater freedom from heart failure readmissions, but they suffered from a significantly increased rate of the things that we commonly associate with redo heart surgery. And this is what a valve-in-valve looks like. If you don't fully expand that TAVR valve inside the other valve, you get this pinwheeling, which restricts leaflet motion. The question is, what's that going to do to durability, and what's the potential for patient prosthesis mismatch? So if you look at the catchphrase that people use about the lifetime management of young patients with aortic stenosis, if you start with TAVR and you go down the right side, you can keep putting TAVR valves in TAVR valves, but eventually you're going to run out of room. And the surgical options are associated with very high mortality. If you start with SAVR, the first or the second intervention is low risk, as are most of the third intervention options, until you get into that SAVR after TAVR option. And then I have to bring out the worst case scenario, the doomsday scenario, where we're faced with an epidemic of failed TAVRs in patients with the potential to live a long time, and a lack of surgeons trained in aortic valve surgery as a result of declining SAVR volumes. So how do we move forward? We need better comparative data in young and bicuspid patients. We need to understand the need for and the risks associated with heart surgery after TAVR. We need long-term survival and durability data, continue to optimize patient decision-making, and it's imperative that as cardiac surgeons, we remain part of the conversation. Craig, I just want to say that I hope you understand that your legacy lies not in those of us who you've trained, but in the patients or in the people and young people that we continue to train. We tell them to think 3 steps ahead in the operating room and to keep operating no matter what. We teach them about being self-critical and accountable. And more than anything like you, we teach them to love heart surgery. Thanks.
Our next speaker is Bo Yang. Bo's become quite famous for his operation, this annular enlargement. I was just at AATS in Lisbon, and there's an entire session where they were debating various approaches to a small annulus, and they were all talking about the Yang operation, and he was sitting there in the audience, and you're such a modest person. He never got up and said a single word. So, congratulations. You're now famous, at least at AATS, and we'd like to hear a little bit more about this.
Good morning. When I was a general surgery PGY2 resident, PGY3, and asked Dr. Copeland, Jack Copeland, to contact Stanford, and he talked to Bobby and brought me to Stanford for elective rotation. I spent 2 weeks with Dr. Miller and 2 weeks with Dr. Mitchell. That was days and nights, and I stayed with the old lady temporarily for months. She never saw me, and she was going to call the police office to find me. I shouted at Stanford, I eat at Stanford, sleep at Stanford. So that was how I got into the CT fellowship, and the 3 years, it was a beautiful 3 years. And I like to contribute, attribute this idea as technique to Dr. Miller, because he always sent the papers to us to read. One of the papers he sent to us is by Bobby and Robert Anderson about the surgical anatomy of aortic root. That's one paper said it's forgotten interleafar triangle, all these things. I read all this and I summarized like 10 things of aortic root. One day I was at the CATH conference, we're presenting a case. I said, this is 10 structures of aortic root. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Then we had the wet lab, and in the elevator, Dr. Miller stopped me, and Dr. Bobby Robbins was there too. Dr. Miller said, Bo Yang. I said, what did I do wrong? I said, yes, Dr. Miller. He told me everything you said today about aortic root was correct. I said, wow, that's really a compliment, because he never said anything I did it right. It's always that something I did wrong, correct me. So that's the, I really like, because of all the knowledge I learned at Stanford and other things, I really want to attribute this to the education from Stanford. Briefly talking about the ideas and the operation. So people always talk about the aortic valve annulus small. The aortic annulus, it is normal, it's 17 to 25 millimeter. That's normal for everybody here. People run marathon with it if your valve is normal. So the area is about 3 to 5 centimeters square. That's normal. And the problem is the valve is too small. The opening of the valve is too small. If I have 23 valve, look at this here. And here, the opening is 16. If this is 21, it's 14 millimeter. And only 29 valve has an opening 23. So if everybody men here, you have 23 annulus, you need a 29 valve to match your native annulus. Otherwise, it's just too small for you. What happens if we put a small valve there? Oh, this is an FDA study showed the same thing. Say 29 valve by 4 valve company, now in the 4 valve company, average 23. It's not just we direct measure. 27 average valve end up 21 millimeter opening. This is the maximum opening. This is from FDA. That's why FDA required and mandate all the valve company put a effective orifice diameter under every valve label. This is very important. So we understand this, the valve label is mismatched, is really mismatched to the real size of the opening of the valve. What happens by doing that? So normal valve, 19 to 25, normal areas, 3 to 5. The valve is so small, it's 12 to 18 now, about 7 millimeters smaller. The area is 1.2 to 2.4. By doing that, we size the area of the annulus of each single patient, put the valve in without the enlargement by 50 to 70%. Basically, we convert a severe aortic stenosis to moderate stenosis every time we put the valve in without the enlargement. So we really need to upsize by 3 to 4 valve sizes to create an opening match the patient's native annulus. That's the concept we should do. And TAVR valve is the same. It's 23 valve, 15 millimeter. The Sapien 40 millimeter measured. It's very small, the opening. 34 valve. Does it mean the opening is 34 millimeter? No, it's 24 millimeter. You talk to the company, it's only 24 millimeter, 24.5, be more accurate. This is nothing new. This doctor, Rahitullah, 1978, defined the ppm. He found out that the prosthetic valve area is about 1 to 2.2, 2.3. The normal area is about 3 to 5. He said in this paper, every prosthetic valve has a ppm immediately when put into the patient. This is nothing new, actually. So next Vial trial here. This is so small annulus, less than 23. Valve uses size 21. Look at the opening of the valve, 1.4, 1.6. No matter TAVR or SAVR, it's very small. Gradient is high, teens. It's one patient sitting there, lying on the bed, doing nothing. Your gradient is already this high. If it run, how high would it be? It will be 50. So if the valve area is so small, 1.4, 1.5, the valve will last long. That's why Notion trial, the valve, SAVR valve didn't last long. It's really bad for surgery. Valve size matters. It's size 29, it's 23, 27, 19, 21, 29 people. Survive much better. So this annual enlargement we developed is different from traditional idea. Traditional idea is cut down. The deeper you cut, the top open more. Instead of cut one cut, make 2 cuts into the fibrous trigon. We can enlarge the annulus from 21, 23, can hold the valve 29. Look at this here. This technique enlarge the surgical annulus is crown-shaped surgical annulus. Doesn't do anything to the basal ring or the LVLT. If a patient come here with the LVLT basal ring is 23 millimeter, the valve is calcified, the valve doesn't open. Take the valve out, put the 23 in. 23 valve has opening 16 millimeter. So you have a bottleneck of the valve. So this is ppm. If you enlarge the surgical annulus, put the 29 in with opening 23, it matches the patient's native annulus LVLT. So this is the restored normal anatomy, normal size. That's why you do not need to enlarge the normal LVLT and the basal ring. You enlarge the surgical annulus, put a large valve in. That's the whole idea. And look, this is about 120 patients or 170, 80 patients. Size is 21. Most time we put 29 in basically. And it's very safe to do it. When I showed this idea to Dr. Miller, what he told me is, Bo, be careful, don't kill patients. He always tell me don't kill patients. I always try something, don't kill patients. I said, okay, I'll try. We had one mortality here. This patient had actually radiation of the whole body, had the MVR and the AVR, capture time 3 maids. She died of mesenteric ischemia from actually in the ICU, unfortunately not detected. One question is about, does the valve tilt? The valve does not tilt here. So it's 23, you notch the aneurysm, put the 29 in, sits very well perpendicular to the flow. Look at this 29 valve. The housing, the strut, so you occupy so much space and then end up opening 23 millimeter, matches the patient's native basal ring and the LVOT. So you need a 29 for regular size male. So this is mechanical valve, same thing. This obese lady, BMI 53. This is 19 millimeter. You enlarge for 27 top height valve in perpendicular to flow, no tilt. Look at the opening, the inner diameter of the mechanical valve matches 19 millimeter, 20 millimeter. So you need this really upsize 3 or 4 valve sizes to give an opening of the valve matches the LVOT. And showing here is this is after the enlargement. There are 2 goals of this enlargement. Number 1, give it better hemodynamics. Number 2, set up for future valve involved TAVR. Look at here. The VTC is about average about 5 to 7. And the V2A, STJ is not sequestrated. It's about 4 to 8. So you got plenty of space for the in the future valve involved TAVR without blocking the coronary arteries. This is a sample here. 23 annulus. Now to put the 29 valve in, you got a lot of space between corner and the valve and the aorta between the valve. So put the valve in valve top there, blood flow goes to corner easily without any obstruction. And many papers show there's no difference between AVR and AVR enlargement because they don't match the annulus. We did a study, if you match the annulus size, one group had AVR, one group had AVR enlargement. The survival, 6-year survival was 96%, 98% were over 74%. The annular enlargement has a ratio of 0.2. It's very protective. You have to match the annulus to show the difference. Like you do like the Vial trial or small trial. Otherwise, you won't see any difference. So TAVR, just Robbin talking about TAVR. Is TAVR going to take everything away? This is a TAVR valve, same patient. Look at this TAVR valve, how small it is compared to enlargement. Here's the video of this this procedure here. I just want to this is it playing? I hope it's playing. It's playing now. Okay, so this is a 72-year-old patient, and 2 years, 74, 2 years ago, TAVR got better, and has severe Patpilai leak and moderate AS. So came to us, and look at how small the root is. Very small. It's only 19 millimeters severe AI and the moderate AS. What we did, we took the TAVR valve out. You can see the TAVR valve, and took it out, cut it out, and be very careful. Just you have to use sharp dissection for this, otherwise destroy the root. And once we cut it out, we enlarge it with the one incision. It's 19 millimeter. Just cut through the left non-commissure and then cut into the left fibrous trigon right underneath the aortic annulus and then right fibrous trigon too. You have to cut it big in order to upsize 3 to 4 valve sizes. And then once you cut it open, it's how big it is. It's huge, the root. This is called arc modification. Try to maintain the aorta mitral as much as we can. So you saw the patch there, and you can see we still maintain a lot of aorta mitral curtain, and the upsize is 25 millimeter. And this patient has allergy, so we put the valve without the allergy there, and there's 25 valve in. And I do not use cornuts. I know Dr. Wu does not use cornuts. And our residents only learn how to tie with me. The rest use cornuts. So this is the size of the TAVR valve. You can see 1/3 of it. Even use a frame for 1/3 of it. That's how we win. We'll have the enlarged root pathology valve to win this battle. Look at compared to TAVR. TAVR, the EOA doesn't change, and you match the annular size too. And with the enlargement, the EOA keeps getting up. The gradient keeps going down. TAVR start going up, and you see DI. Oh, this is regression, LVH regression, significantly much better than the TAVR in the enlargement group. So we talk about the reduce. Look at TAVR in reduce, match the original previous valve size. TAVR increased EOA a bit the first year and drop down second year. Look at with the enlargement, you take the old valve out, put the enlarged valve in, continue increase the EOA. Gradient continues goes down. With the redo valves, SAVR with enlargement is much better than TAVR because TAVR is limited by the first valve, and SAVR enlargement would take the first valve out, enlarge it, put a large valve in. That's the advantage of doing with the more invasive procedure. You have to give patient better outcome. No PBM in the enlargement group, 19% in the TAVR group. Just 2 patients had the intravalvular mild AI. You have mild moderate AI, 26% in the TAVR group. So in summary, is the annular enlargement really provide better hemodynamics than SAVR alone or TAVR alone. It's excellent setup for future valve in valve TAVR. We use enlargement for every AVR, just as Lima to AD. Every case we think about enlargement AVR. If we cannot we cannot put the largest valve in, and yeah, this is last slide. The lifetime management to us is large valve in first size, upsize 3-4 valve sizes. Probably last longer because orifice is bigger. Then if he needs it in 15-20 years, it's very easy to do valve in valve TAVR. Thank you for your attention.
All right, we're going to welcome Pat Kasinpila up to the stage here. Pat's one of our recent trainees and our most recent faculty member, and we affectionately call her Perfect Pat.
Good morning, everybody. All right, so my talk today is going to be on valve-sparing aortic root replacement. I have no financial disclosures, just a personal one that I can't claim to be an expert, but I am lucky enough to have been surrounded by many who are. So the goal today is to distill this topic into 10 minutes and share some insights into the history, techniques, and future directions. So by the 1960s, root replacement with composite valve grafts became the gold standard for treating root aortopathy. But it was clear that we still needed a durable option that avoided anticoagulation and complications inherent with prosthetic valves. So valve-sparing aortic root replacement really revolutionized the management of root pathology because it restored function to the root while preserving the native valve. This can be subdivided into remodeling and reimplantation. Each has its strengths and challenges, as we'll explore. So we really have to credit Sir Magda Yakub here for pioneering the aortic root remodeling technique seen there in the hat in the 1970s. It's rather an elegant approach to treating the root by excising the deceased sinuses while preserving the buttons. He then replaced the root with a tailored graft with 3 tongues extending into each sinus, creating neosinuses. This maintained the physiologic geometry of the root, but its drawback was the absence of aortic annular fixation, which may predispose patients to annular dilatation and recurrent AI later on, especially in connective tissue patients. So in the late 1980s, Dr. Tyrone David's reimplantation technique addressed these issues by anchoring the annulus within a straight tubular graft, providing long-term stability against dilatation. But even he himself at the time noted that the normal aortic root is a dynamic structure, can change its shape and dimensions over the cardiac cycle, and the aortic sinuses may be important to decrease the mechanical stress on the valve leaflets. So by this time, it was also on Dr. Miller's mind. So the team here at Stanford focused on biomechanical properties of the aortic valve and the root, aiming to optimize the durability of the valves that they spared. So let's see. Again, the particular concern here was the straight graft with the loss of the sinuses would create abnormal leaflet stress, which ultimately may limit the long-term durability of valve-sparing aortic root replacement. So as this idea took form, it spurred the quick evolution of the David procedure in order to mimic nature and mitigate the potential stress on the aortic valve leaflets. So what started off as a straight graft in the David 1 had now evolved into David 5, where a larger graft, single graft is used and then necked down at the annulus and the middle to create the neosinuses. But by the early 2000s, the Stanford team had also modified this technique and created their neosinuses by using 2 separate grafts. Dr. Demers and Dr. Miller here describe the technique as necking down large proximal graft at annular end, tie the bottom ends, the bottom sutures loosely, transect graft atop the commissure, and use small caliber distal graft. This provided unlimited surgical flexibility to customize all parameters for each individual patient while preserving the natural geometry. Here's a quick how-to. David Feindel formula is used, and then a graft 6 to 8 millimeters larger than the calculated size is used. Miraculously, it's always a 34 necked down to a 29. And then you use 12 non-pledgeted annulus sutures are then placed. And I really like these pictures because it really showed the advantages of the SMOD technique, where if you compare it to the traditional David 5, because the root graft here is trimmed right at the just above the commissures. It's better to see, it's easier to reimplant and perform your valve repairs as needed. And also compared to commercially available Valsalva grafts, these are unlimited choices of annular and sinus diameters, commissure heights, making this highly customizable, plus it's less costly. Sewing the distal end of the large graft here to the second small graft automatically recreated the pseudosinuses. Compared to the traditional David 5, there is minimal disparity in the distal graft anastomotic diameter when sewn to the native graft or the native aorta. Here are some images courtesy of Dr. Miller. You can see the nice neosinuses, neo-STJ here, as well as a relatively smooth distal anastomotic line. It's an on-phos view 14 years post-op in a Marfan syndrome patient, and here's a 2-view echo in a 17-year post-op patient. So those looked great. Let's go over the entire experience at Stanford here. Between 1993 and 2020, 577 patients underwent valve-sparing aortic root replacement using Tyrone David's reimplantation technique. The data are courtesy of Dr. Miller. Pre-op characteristics, the median age was 44. They're mostly young males. Majority of patients had no or mild AI, with 14% with severe AI. Impressively, the completeness of the follow-up was 100% with up to 25 years, and 98% got their echoes up to 24 years. And this was reviewed by a single cardiologist. The analysis revealed that very few patients had moderate or severe AR. So see, the distribution of patients with various types of connective tissue diseases are shown here. Overall, there are 29 patients, 29% of patients with Marfan syndrome and 7% of patients with Lloyd-Dietz. Early in our experience, the procedure was solely performed in patients with tri-leaflet valves, but over time it was used in increasing frequency in BAVs with overall incidence of 26% within the cohort. The graph also illustrated the evolution of the type of Tyrone David procedures that were used here. David 1 was used initially, and then that kind of progressed into the David 5, and then the SMOD started in the early 2000s. And overall, the SMOD made up about 72% of all of our cases. And I really like this slide. As you can recall, in 1992, when Dr. David described the valve-sparing procedure, it was intended for people with, quote, annular aortic ectasia with normal aortic leaflets. But as you can see here today, less than perfect valves are increasingly being spared. At our institution, repairs were performed in 53% of the patients and more frequently utilized in bicuspid valve patients. And of those repair, 94% were free margin plication. The outcomes are pretty remarkable. Early mortality is very low at 1%. There are 15 late deaths, 7 being non-cardiac in nature. Type B dissection notably was occurring in 20 patients, or about 3%. 45 patients needed reoperation, all underwent AVR. 8% had structural valve deterioration, including reoperative AVR. So what we saw using competing risk assessment on multivariable analysis of SVD, pre-op severe AR was significant with a hazard ratio of 4.1. Nothing else here affected SVD. Overall survival, 15 years, was 93%. And then freedom from death or AV reoperation was 90%. But if you look at the cumulative incidence of SVD, though, this including redo AVR, we demonstrated 15-year incidence of about 15%. But if you look at just the 414 patients who underwent the SMOD technique, the CI for SVD was just 6.6%. Postoperative type B dissection was significantly associated with connective tissue disease, with 15-year freedom from type B dissection of only 70% in Lloyd-Dietz population, compared to 90% in the Marfan's population and 99% in people with no connective tissue disease. This is alarming, but consistent with other large centers' experience with connective tissue patients. Risk factors associated with post-op type B dissections included Lloyd-Dietz with hazard ratio of 10, Marfan syndrome, and potentially the original TD procedure with p-value of 0.04. So in conclusion, the SMOD in select patients yielded encouraging 15-year durability. People with severe preoperative AI are at 4 times higher risk of SVD. BAV patients did not experience more SVD than tricuspid, tri-leaflet valve patients so far, but longer follow-up is, of course, critical. The SMOD technique had no discernible impact except on more late type B dissections. And type B dissections remain an unsolved major challenge in connective tissue disease patients. Operations are done by surgical residents, so it is teachable. And if you need confirmation on that, just ask your neighbors. Seasoned judgment, of course, is key to determine which valves should and should not be preserved. So what's next? Technology with temporal and spatial resolution to help us better quantify aortic root dynamics, tools to predict distal aortic events, leveraging flow dynamics and advanced imaging, longer follow-ups, especially in BAV patients, more in-depth understanding of genetic mutations causing connective tissue disease and aortopathy, and perhaps we may be looking at personalized surgical strategies in the near future. This is what I'll leave you with. This email from Dr. Miller. It's a picture of Dr. Tyrone David's slide showing how he does his valve-sparing aortic root now in connective tissue disease. Dr. Miller in the email said, Tyrone David has come around and now in CTD patients creates neosinuses with 2 grafts. Look familiar? Yeah. All right. So to wrap up, I want to take a moment to reflect on the profound impact you've had, Dr. Miller, not just on the evolution of valve-sparing aortic root replacement, but on all of us here in this room. As I look around, you see not just colleagues, but really a community bound together by your leadership and your unwavering commitment to excellence. Your career has left an indelible mark on all of us. And on behalf of everyone here, I want to say thank you, Dr. Miller, and congratulations.
All right, I want to call up Mike Ma, another one of our graduates who somehow went into congenital, but he is now our division chief of the congenital group, and we've asked him to talk about the Ross operation.
Thank you. It's an honor to be in front of all of you here. I recognize a lot of familiar faces, a lot of people that have helped train me over the years. I'm extremely appreciative. Of course, at the very top of that list is you, Dr. Miller. I've been tasked with talking about the Ross. I do some Rosses, but I'm clearly not an expert in the Ross compared to many people in this room. So I'll just use that as a disclaimer to begin with. The other disclosure I'd make is that probably like all of you, we're heavily biased by the surgical mentors we've had before us. And so the views that I'm expressing here are certainly biased by those things. Dr. Miller sent me about 4 emails in the last 2 weeks since he knew I was going to present on the Ross. These are some of those pictures. The first email I got was 2 weeks ago, and there was no title for the email other than to say, Pat, as a PGY2, could do a subcoronary scalped freehand autograft AVR in the lab. He sent me this picture of that, I think, pig valve being done in the lab. And I think his message to me at the time was that the right way to do the Ross is through a subcoronary scalp technique. The second figure is something I dug out of my own iPhone collection, and I think I see this circulating on the slide, so I don't think I'm the first person to debut it here, but I think this is a picture of Dr. Miller at some point in his career, and I just wanted to make, I didn't have another place to put it on the presentation, so I wanted to make sure to highlight that here. And the third figure, which was from another email Dr. Miller sent me 2 weeks ago, this was, I think, a patient of his that had a probably successful subcoronary scalp Ross technique performed, and the patient, I think, is doing well without autograft or homograft reintervention 24 years later. Since I submitted this presentation, I got 2 more additional emails from Dr. Miller that I did not have time to enter into the PowerPoint. I think one of his cautions for all of us was, if you look at the most recent sort of single and multi-center data, there are many centers that are attempting to do the Ross procedure who have very low volumes and have marginal outcomes. So this is still quite a technical operation and should be treated with that level of respect. So the adult Ross Renaissance, which I think we're in the 3rd iteration of since it was invented in the 1960s. I'll just go over this very, very quickly since there are many more experts in this room than me. This was the original paper describing the Ross operation in the Lancet in 1967. Interestingly enough, this described both the Ross 1 and the Ross 2. For those of you that don't know the Ross 2, that is when you take the same pulmonary autograft, invert it, put a Dacron sleeve around it, and try to implant it into the mitral position. And as you can see from the original description for Donald Ross, the aortic position is a subcoronary scalp graft that's placed inside the native aortic root. Now, these were the only pictures that were published in this Lancet article, which was literally a page and a half long. So there really wasn't much schematic on how to do this procedure other than it was successfully done by this master surgeon. Since that time, some of the other sort of high volume single center outcomes for the Ross procedure, this is one of the largest series coming out of Hans Siever's group in Germany, 501 consecutive subcoronary scalp Rosses, very low autograft reintervention rate. He describes in great technical detail how he performs the procedure. It's very important to follow the annular suture line for the basal ring, which you see here. And then they describe hitching the commissures up by about 1 centimeter to try to improve leaflet coaptation so that there's less aortic insufficiency when the autograft is implanted. There are several other popular techniques that probably many of the people in this room use more than the subcoronary scalp. Actually, can I ask real quick, does anyone do a subcoronary scalp Ross here? Am I allowed to ask for audience participation? And how many people are doing total root Rosses with no reinforcement? And how about reinforced Rosses? Okay. Okay, so I mean, there's probably 10 people in this room that raised their hand for all these different procedures. So I'll just quickly go over those other techniques. The total root recently repopularized. Dr. El-Hamamzi in Mount Sinai has one of the largest series on this now. The pulmonary autograft is harvested in the usual fashion. As we all know, we need to be careful for the LAD running behind and the first septal perforator. And then the implantation of the autograft is importantly done in this described technique with interrupted sutures all the way around the LVOT. And it's important to place those sutures within the LVOT to ensure that the pulmonary autograft is supported to prevent basal ring dilation. The other key concepts for this version of the total root Ross include trying to support the pulmonary autograft with the non-coronary cusp, as well as the pillar of the left to right native aortic valve. And that's the completed reconstruction. This you guys may all be familiar with. We had Dr. Starnes here for a visiting professorship about a month and a half ago. This is Dr. Starnes' technique for the Ross. This is the reinforced Ross, or the inclusion technique, where we place a straight Dacron graft around the pulmonary autograft and then implant that to try to reduce the risk of long-term autograft dilatation. This procedure has shown in his series to have a much lower rate of reintervention out to 10 years versus a non-reinforced Ross. Some of the material that we've been working on here at Stanford, this is in Dr. Wu's clinical translational research lab, where Dr. Zhu, one of our excellent residents right now, is looking at simulating the Ross in different configurations. This was the Ross being implanted either in piglet form or cadaveric human form into a Valsalva graft or a straight graft, or in this case, a straight graft with anticommissural plication sutures placed, and demonstrating that in that configuration, the valve leaflets had the best biomechanics. I think what's really interesting and exciting about this type of research is that it's very quick to translate into human trial, essentially, because if we find something of interest in the engineering lab, we're able to try it almost immediately in the OR. And this was a case report that was published of, I think, the first beating autograft anticommissural supported Ross in a human. So these are the limits of sort of what I wanted to talk about in the adult world. In the pediatric world, we've derived a lot of inspiration from the initial procedure, the Ross. And I think conceptually, what's most important about the procedure is that we are repurposing one of the good outlet valves to be used in the more hostile environment, the systemic circulation. So certainly from that procedure, there have been many subsequent offshoot procedures where a surgeon needs to really understand the anatomy of the conotruncus in order to perform some sort of root translocation to treat a wide variety of congenital heart problems. We here tried this in a slightly new fashion, and I just wanted to quickly show a case where we used some of the principles of the Ross to help this patient out. This was an 11-year-old child. She was 23 kilos at the time of this operation, which was about 3 years ago now. She had been operated on at an outside institution for arterial switch. She had transposition with VSD. During the course of her young life, she needed a few reinterventions for the mitral valve and the LVOT because there was subvalvular disease. One of the resections caused unhinging of the mitral valve leaflet, and that needed to be repaired. The neo-aortic valve, which was the patient's original pulmonary valve at the time of birth, also needed to be repaired. So this patient came to us seeking some sort of option for recurrent mixed neo-aortic valve insufficiency and stenosis. And we had several options to consider. And ultimately what we chose to perform in this case was because the current aortic valve was functioning reasonably, but not well enough to be a systemic valve, and the current pulmonary valve was working very well, we decided to switch both valves and try to give her longevity this way with two native valves, but repaired in the opposite position. So this is a quick summary of that case. This is the native aortic valve that is leaking moderately with some LVOT obstruction. This is taking down the PA, the current PA from the branch PAs, inspecting the pulmonary valve, which will become the aortic valve, just like in the Ross procedure. We cross-clamp the ascending aorta, open up the posterior root, which has the more diseased valve, as you can see there. It's got two frozen leaflets posteriorly. Performing a commissurotomy to see if that alone will be able to salvage that valve, but we realize that that won't succeed. And then because that diseased valve in the assistant's hand is the most diseased, we're deciding to resect that and bicuspidize this valve for use in the pulmonary position. This is harvesting the coronary buttons. This patient had anomalous coronaries. There's a LAD and our RCA coming from this sinus. And then in the back, you can see there's a circumflex artery. So the neo-aortic root is harvested. This is the equivalent of detaching a native aortic root off an LVOT. This is the equivalent of a Ross harvest here. That's the pulmonary root being harvested from the RVOT conus. This is the right angle passing inside. Try to ensure that we don't damage the current pulmonary root that's going to become the neo-aortic root. And then here, this is probably the most complex part of this deconstruction, which is trying to separate the two roots from the ventricular septum, being very careful near the posterior aspect of this where the conduction system will run. This patient had a VSD, so we know if we stayed above the plane of the VSD, we would be okay. That's a forcep in the anterior mitral leaflet. And again, this is the filleted open root, the one that's going to become the pulmonary root. And this is taking down the LA curtain from the back of this root. And again, there's a posterior coronary that we're being very careful to avoid. And then I'm probing that there just to make sure that I didn't damage that during this deconstruction. So once that's all done, we've finished most of the current aortic valve harvest. You can see I'm just looking over and over again to make sure I don't damage something as I try to take that part of the root off. And then the entire two roots come out together on block. That's the one that's going to become the aortic valve. It's gotten flipped. I didn't show the 180-degree flip, but we flipped it 180 degrees. That's the now bicuspidized future pulmonary valve that we're trying to put together. It's a little too small, so I had to patch it a little bit with a small transannular patch here, which resulted in a little bit of PI at the end. Put the valves back together, sew them each back into their roots, try to follow the principle of implanting the root inside the LVOT to prevent annular dilatation. That's a bovine pericardial strip to reinforce and improve hemostasis. And so that gets completed. Same suture line. I don't sew as quickly as some of my other surgical colleagues, so it takes a little while to get this done. But that's completed, and then we're completing the interventricular septal anastomosis to the front of the neo-aortic root. And now see the aortic valve is back in position. I'm inspecting the LVOT to make sure that that's reasonable, and then we're implanting the bicuspidized root into the RVOT, and you can see the posterior portion of this. So at this point, the roots are completely disassembled and everything's very difficult to tell where everything should go. So I'm slowly putting together the ascending aorta back into the root. And then I decided in this case to put the coronaries back on halfway through the posterior reconstruction of the ascending aorta. And ultimately, I needed to patch the ascending aorta because the geometry didn't seem to lay perfectly. So I put a small piece of bovine pericardium, which you see here, to finish off the right lateral portion of the ascending aortic anastomosis. And then we reanimate the heart, reconstitute the LeCompte, which is the branch PAs, patch augment them, and replace them to the pulmonary root. So that's the Ross or neo-Ross. There's mild central regurgitation there, which was an acceptable result in my mind. And this is the RVOT showing minimal regurgitation with a peak gradient of 11 millimeters across the RVOT. So that, I think I wanted to demonstrate this case just to say that the fundamentals of the Ross have been very helpful in my career. Having Dr. Miller's love of aortic root surgery was very helpful for me as I adapted that into congenital practice. The Ross can be performed safely through many techniques. I think because we're honoring Dr. Miller today, I would say that subcoronary scalp is probably the best technique to use, but it's very technically challenging. For the rest of us mere mortals, the total root may be a easier approach that's more adaptable, but we need to be careful about the long-term outcomes. And then there are many derivative operations that we perform in the congenital space that derive our original loves from adult aortic root surgery that allow us to do it in children so that they continue to function and grow for many years to come. So with that, thank you. I'll echo what Pat had just said before. These are some of my cohort of integrated cardiac residents who have all benefited over the years from Dr. Miller's excellent mentorship. So thank you.
Okay, for our thoracic aortic session, we were going to start off with Mike Fishbein talking about his prophylactic total arch replacements, but he's in the operating room doing one of these. So we're going to have to skip his talk. But again, I really mean what I said. Mike is, a stellar trainee of Dr. Miller's and a perfect example of the success that can be achieved from the Stanford residency. So we're going to go right to Abe DeAnda. Abe is the chief at UTMB Galveston, and Abe is my co-chair in fundraising for the AATS Honor Your Mentors program.
Open your wallets. Yeah. All right, it's a pleasure to be here. Thank you, and wouldn't have missed this for the world. Nothing really to disclose. You've seen this quote already, and this is one of my favorite pictures. And this was a quote that Mark Moon and I came up with when we were writing his memoir, his biography for the JTCVS, and felt that this was probably the most appropriate quote that we could attribute to Craig, because it sort of, for a number of reasons. One, Craig's a big philosopher. Craig reads more than most people read in a variety of things, a true polymath. The guy who wrote it is Spanish. So we had a lot of reasons why we had to attribute this to him, but this is Craig. And, but this is Craig too. When you get one of these pictures at 2 o'clock in the morning, all I'm thinking about is I'm not looking at the size of the rack or what the rifle he's holding. I'm thinking about the potential for venison jerky that I might be getting in the mail. You never know, but sometimes it happens. But that's the big game. But Craig taught us some other stuff. Big game. This is an early case that I was sent years ago. A guy with Marfan's. Someone had repaired a Type A. Just did the ascending portion of it. Now you can see the abdominal portion as well as the arch, and the buttons, the coronary buttons are measuring about 3 centimeters. So they asked me to take care of this, and we'll get to more to that later on. I'm going to talk mostly about the history in the time that I have, a little bit of history of thoracoabdominals. Just to let everyone know where we where we came from and where we're heading to. This was the earliest paper, one of the earliest papers describing a series of patients. This was Michael DeBakey's a series of 4 patients. They had a bee in their bonnet. They somehow did 4 patients in about a 6-week period. I think because they figured out they could do it, they just did it. They just got 4 patients and just did them all one after another. They had a 50% mortality rate. This is obviously done off pump. The first patient was done clamp and sew, and the next 3 were, a shunt was used. Dacron did not exist, so they used homograph, and they described the thoracoabdominal incision. This is pictures right out of DeBakey's paper. You know, some people like to use a Sharpie to describe something that none of us else can see, whether it's an aneurysm or a hurricane path. But you can see it right there. That's the aneurysm. So they did the initial 4 patients, and then they just stopped. And then they waited, and then they started doing them again, and they got up to 42 patients. Mortality rate got a little bit better. Dacron was invented, and now they're using Dacron. And the second author in this paper is Stanley Crawford, who's going to play a huge role in the history of this disease. But these 42 patients, as I said, they did better. Renal failure was the biggest issue that they saw for patients that survived. And for patients that died, they were dying from cardiovascular disease. And nowhere in any of these papers do they mention paraplegia, interestingly enough. Here's the guy, Stanley Crawford, takes a huge interest in thoracoabdominals and starts accumulating data, which is all important, of course, and he has these groupings. This is an interesting point for me. He groups them. We sometimes use the term extent or type. In his original paper, it was group 1 through 5. 5 actually was not a thoraco. 5 is a pair of a juxtarenal aneurysm, but he included in his grouping because he made the same incision. And the other thing that Crawford starts noticing for the first time in the publications, of course, is the paraplegia. This is a problem. No one else has really talked about it, mostly because I think these patients were dying before they had a chance to wiggle their toes. So, but this is Crawford's groupings 1 through 4. And this is a paper actually Joe and his colleagues, part of a ACS lecture series. They added the extent 4 has been added as part of the grouping for aneurysms that start in the middle of the descending aorta. Going back to the Crawford era, he used an inclusion technique initially. And he really was focusing on both paraplegia and as well as visceral ischemia, and trying to do a lot of different measurements, and started showing that paraplegia was a big deal, but it had a lot to do with where the location of the aneurysm was and how it was dealt with. He started modifying his technique. Instead of having an inclusion technique, started doing a circumferential transection of the aorta and then sewing it end to end. Started reimplanting the intercostals. Started doing stage repairs with an elephant trunk. Used CSF drainage. These are all things that we now use probably routinely. And in this paper with 1,500 patients, I had a mortality rate of 8% in 30 days. Nick Kachukis introduces the use of circulatory arrest, and he was doing this mostly to preserve both the viscerals and the spinal cord. A big advocate for circulatory arrest. He did not have the numbers of either Crawford or Casale, but he did have some really good results that matched those coming out of Houston. And this is the Houston experience with Dr. Casale, over 3,800 thoracoabdominals now. Their mortality rate, 38 mortality rate, 7.5%, which is actually very similar to what both Crawford had and what Kachukis had. So going back to the patient that I showed the picture of first, this is what I was given. I started off by redoing the ascending and then the arch, debranched it, and did an elephant trunk. And then said, okay, I'm going to have to face the abdomen and the descending at some point, which we did about 30 days later. And this is the end result. With everything bypassed, we bypassed it all the way down to the femorals. This guy did have Marfan's. Everything was large. And the other part about this picture I want to point out is that if you ever want to see the difference between a gel weave graft and a hemoshield graft, the gel weave graft is white, the hemoshield is red. So one of them does actually bleed a little bit more than the other. But I didn't have a branched gel weave to do the femoral. So that's what we had. So just want to reflect in the last 2 minutes or so of working with Craig, both in the lab and as a fellow. As has already been mentioned before, we learned a lot, and we learned a lot because the fellow did the case. We did the entire case, no matter what, and it was great. It was a great experience. It bolstered our confidence, and you know, it didn't mean that it was a really unicorns and rainbows. Craig did say a lot of things that, you know, hurt you just a little bit, but you know, but that was okay. You know, when we were told close your eyes and think, yeah, you knew that you were missing something big. So the other thing was this: I trained in the pre-80-hour work week, and the call schedule reflected that. When we were on the service and we knew that there was going to be some thoracoabdominals on Tuesday and thoracoabdominals on Wednesday, we would alter the call schedule so that we were on call those days because we were going to be in the hospital all day anyway. And we would just say, okay, we're going to take call those days. And so nowadays, with all the limitations, you can't do that. There are high expectations of us as fellows, and also in the lab, and there are great rewards. But there was every once in a while, like I said, you get your feelings hurt just a little bit. This is still my favorite note. I kept this. This is a sticky. I don't know if Mark still remembers this, but Phoebe, he directed Phoebe to remind Mark and I that something that we did was wrong. But he left a paper on our desk chastising us for not having read a paper of like the 50 papers that we had referenced on some article that we were submitted. So yeah, we took our blows, but we learned a lot. Anyway, I'm really happy to be here. Craig, I wouldn't have missed this. We learned a lot from you, and I can honestly say there are patients in this world alive because of you through our hands. So thank you.
Well, we talk a lot about the impact of Stanford on transplantation, and we also talk about the impact on aortic disease. But I think we should all recognize that Stanford's pioneering leadership in TEVAR was really phenomenal, and that was really a project that was put together by Mike Dake, together with Craig Miller and Scott Mitchell. And we all know Scott to be an amazing technician, surgical technician. That's one of his major reputations. But I asked Scott to talk a little bit about TEVAR, really to sort of bring back the history of exactly how these three individuals pushed an entire field forward. So Scott, welcome.
Good morning, barely. I think the first thing to say is this endeavor is a typical Stanford thing. You meet people that you start working with you didn't know, and you find out that they're incredibly talented, they know what you do, and your work meshes together so well. And that was the perfect example was Mike Dake, starting to work with Craig and myself, who was an extraordinary interventional radiologist. But to begin, You know, Craig was born and raised in Reading. His father was a physician who has been described as the pillar of the population in downtown Reading. He then moved to New Hampshire to attend Dartmouth. And as best I can tell, his major was downhill ski racing. And then came out to Stanford in 1968 for medical school. He actually spent 4 years in medical school, which is a little bit out of the Craig norm, but even then was working sometime in part of Shumway's labs and developed a lot of interest in the aorta. He then did general surgery residency, as we all did, cardiothoracic surgical residency, and vascular surgery residency, and came on staff after 7 years. Do the math. I took a similar amount of residency training, and it took me 14 years, including 2 years in the Navy. I don't know. I guess Craig's just a rapid learner. So there was obviously a lot of interest about aortic dissections. And so one of the things we tried to do in our lab was to replicate dissections and use that as a basis for trying to devise better repairs than what we were able to do clinically. And while we were messing around with the dog aorta, Mike Dake comes in to watch. And he says, "What are you guys doing?" He says, "Well, we're trying to figure out how to fix these dissections." So he left. And about 2 weeks later, he comes back and he says, "Maybe you should try this graft." I went, "What graft?" So in the 2 weeks, he had devised this stented graft from, these are stainless steel Z stents. I think they were used in the biliary tree, self-expanding stents, hooked them end to end together, and then sewed them into a slightly smaller background graft. And presto, we now had a TEVAR, an endovascular graft designed for the thoracic aorta. That was the easy part. We then petitioned Stanford to try and get IRB approval to use this in patients. Well, of course, one of the big disadvantages of this graft was that it required a 36 French sheath in order to introduce it into the human being. And there were no animal models that you could get a 36 French sheath into. So we didn't have any animal models which the IRB would really have appreciated. And it took us quite a long time to finally get approval. It was probably facilitated by Juan Perotti in Argentina, had been at the Cleveland Clinic, came back to his home in Argentina, and put in the first balloon expandable stent graft into the abdominal aorta. And I think our IRB saw that and saw that perhaps this stent graft technology might be of some utility. So a year later, in the history that is actually recorded on some of these stones out in the walkways, we performed the very first thoracic aortic stent graft using this material. It was successful, and we used it sparingly initially. It had two major limitations. One, of course, was the size of the introducer sheath. The other was when you saw Mike pulling with all his might to try and get the sheath off the stent graft, you realized that this was perhaps not going to be perfectly placed anatomically. There might be some variation. That was a disadvantage. But that worked out well, and we used that in our armamentarium for a while. But we also then got involved with a couple engineers from the W.L. Gore company, and they were interested in trying to manufacture a commercial product, which they did. And it was first used in 98, called the TAG. And this was a beautiful graft on an introducer sheath and then covered with a cloth covering with a sort of a ripcord. And so the deployment was very, very accurate. The size sheath was about half the size of our own sheath, and became obviously a real favorite with for us and for 5 other centers that were involved in a trial that lasted for 5 years before the FDA finally said they would approve it for commercial use. Since then, this field's exploded. There are currently 3 major companies producing thoracic stent grafts, at least at the time. Gore with a TAG, Medtronic with a Talent graft, and Cook with the Zenith TX2. And clearly, it was markedly appreciated that avoiding a big thoracotomy in sick patients was a big advantage, and the field flourished. And now there are grafts that can start in the ascending aorta, triple branches into all the aortic arches, arch branches, and in a sheath that's still smaller than even the first Gore graft. So I think it was groundbreaking. It really exploded the field, and I think it's been a big benefit to humans and motivated a lot by Dr. Miller and Mike Dake. And I would say, Dr. Miller, that we appreciate the ability to have this in our armamentarium and the teaching that you imbued upon us, and appreciate all your efforts. Thank you.
Okay, we're going to ask Chris Malasry to come up. So Chris, in perfect tradition with the teaching theme, is the residency program director at Northwestern. And also very importantly for this topic, he led the AATS expert consensus document on aortic dissection, essentially the surgeon's response to the cardiologist guidelines documents. So thank you very much for doing that.
Thanks, Joe. Thanks. Good morning. I've already been informed that some of my slides have been censored. So let's see how I could stumble through this and see what's missing and still see what's there. Thanks, Joe, for asking me to come back here to Stanford to talk about dissections, guidelines, and innovations. And just to put my experience at Stanford in some sort of context here, I know a lot of you here would bleed crimson red if I cut you. I spent 1 short year here. I mean, I didn't spend 19 years here like Abe DeAnda. I did not spend time in Craig Miller's lab. I did a fellowship here. And actually for part of the year, because I was working with Phil Oyer at heart transplants, I don't even think that Dr. Miller recognized me as a human being. Because the only thing I contributed his day was delaying his case in the operating room. And I checked this picture, and yes, I was standing on the right side of the table, I think doing a valve sparing root replacement. So that is my context. So I'm a little humbled why I would be speaking in front of all you here. So let's see, we could learn some things here. I'll talk about 3 things: current guidelines and type aortic sections, all dissections, where there are concordance and discordance between a lot of guidelines. And maybe we could highlight some Stanford contributions to the field of aortic dissection. I think for your library, the 2 surgical guidelines exist for type A and type B. And this guideline document that I published with a lot of people in the room here taught me some politics as well. This was commissioned by Mark Moon when he was president. And you may wonder why Craig Miller's not on this list, because I was instructed by leadership that only one surgeon from every institution could be there. So Mike Fishbein is on it, but in true political form, there's 2 people from Cleveland Clinic because one of them was an incoming AATS president. Craig, you should have been on this publication. There's sort of 3 omnibus aortic guidelines that exist out there, not just dissections, but sort of like the whole thing. And more politics here, 1 American guidelines and 2 European guidelines. I think the EACTS paired with STS to try to get something out before the ESC. You sort of wonder why you need so many guidelines when all the guidelines say the same thing. But on the other hand, when they're discordant, you wonder why that's the case. Are we looking at the same things? And not to keep, we have some Asian guests here. Asians also set of publications, the Japanese and the Chinese. My medical student would happily translated this Chinese one for me. Okay, where did the guidelines become discordant? When I first met Dr. Miller, I was like, boy, Dr. Miller must be the sheriff of our specialty, because he's always never too far away from a gun. And he never hesitated to tell me about surgeons who should go to jail for things that they were doing wrong, or especially things that he didn't agree with. So let's see where we can do some policing here. There is 3 classification schemes. As you recognize, the one on the left, Stanford Type A, Type B. The SVS STS put forth a different set of classifications, mostly centered about where the primary interval tear originated. And of course, the Europeans have a modification of the Stanford classification, which I'm sure some of you object to. So just to highlight it, how would you classify this patient here? This patient has a primary intimal tear in the distal arch of zone 2, and it extends proximally the ascending aorta, so zone 0, and extends distally. So I think for the classic classification scheme, this would be a type A aortic dissection because it involves the ascending aorta, so classic definition. The SVS one would call it a type B aortic classification, so pretty confusing. That's based on the location of the primary tear, so discordance. Well, what about this particular case? Primary tear also in zone 2. It extends proximally but into the arch, but does not go into the ascending aorta distal extension distally. So ATS would classify this as a type B. There is no involvement of the ascending aorta, it just goes proximally to the arch. The Europeans have this classification of a non-A, non-B classification, just arch dissection. So I would propose to you, keep it simple. This original publication by Pat Daly, you see Stinson, Shumway, made it pretty simple. In common language, please, the marked difference exists both therapeutically and prognostically based on whether or not your dissection extends into the ascending aorta. And I would make a plea that guidelines or someone fuse these guidelines, have some sort of common language. So I still rely on type A, type B classifications because we automatically know that we're going to go to the operating room with a type A. Joe Wu showed this. This publication was the first to propose that you should do a graft replacement of the ascending aorta. And this was a time when people were still tossing about the idea of treating them medically. Some people would open the ascending aorta and do a fenestration. Some people would just open it, sew it back together. None of that worked. But Stanford, I think, was the first group to propose Dacron replacement of the ascending aorta. And it still mystifies me why we can't do that correctly. This is a picture of Dr. Miller experimenting with hypothermia. So that's a canoe in the picture there. And this picture is provided me by Steve Landsman. And that was back in the time when you would put the patient in the canoe full of ice to cool them down. You'd have to do the sternotomy quickly before they fibrillated. So I'm sure it was an exciting time. But Let's see some surgical video about the right way to do an ascending aortic replacement. And this is where concordance does exist between everybody. You want to resect all the ascending aorta, all of it, including the proximal tear, with an open distal anastomosis. And this is how I do a open distal anastomosis. I've tried every single variation. I use felt strip on the inside and on the outside. Try to close that false lumen. And I can't remember why I'm using minimally invasive, using the chopsticks here to do this anastomosis. It must be a deep Midwestern patient. But the suture lines incorporate both felt strips, all the aorta, all the Dacron graft. The whole point is to avoid distal aortic new entry tears. There'll be less bleeding. And if you're going to resect all the aorta distally, you might as well resect all the aorta proximally as well. Here's an aortic valve resuspension, and you want to put the stitches right at the tips of the commissures. And that's going to be a target for you later. You put them on all three and resect all of the ascending aorta down to the sinotubular junction. Because if you don't, and we see this a lot, Abe showed a video of like a large amount of ascending aorta not resected. This is a video of a large amount of ascending aorta that's not resected proximally. Here's like 3 centimeters of aorta that the surgeon did not replace. I think that if the surgeon had taken all this, then we wouldn't have to do this operation, second operation at all. So interhospital transfer. So we're not frontier general surgeons. You can transfer your patients, and there's also concordance here. I think everyone agrees that multidisciplinary aortic teams are the best way for all aortic cases, not just dissections. And it's okay to transfer your dissections out. And this is the paper that Joe Wu was referencing earlier, the Goldstone paper. This paper not only showed that it was okay to send type A dissections out of your emergency room somewhere else, but also to bypass all of those small centers in between that also don't do dissections and get your patient to a high volume center. So this is a important paper because it allowed us to set up a code aorta program at Northwestern. We borrowed a lot from Cohen's group at USC and also Kat Harrington's group at Baylor. And we set up this program. We have a hotline. This is a nice hotline because the ER doc gets to talk to both the vascular and the cardiac attending all in one line. And another feature of this program is that if I can get imaging before the transfer, then we'll skip everything in between. The patient will go from the ambulance bay directly to the operating room. That's sort of nice. When we get the call, I accept the patient. I sort of know we're going to be operating in 2 hours. Everyone, gets their gear together and comes into the hospital. And we found that we can cut times by about 90 minutes by going directly to the operating room. Our volumes continue to increase, and it's not just volumes. So we do 80 type A's annualized for this year, 65 type B's. We also take ruptured AAA's. But gratifyingly, you see on that bottom line that our outcomes continue to get better. I think it's because patients aren't stewing in malperfusion for multiple hours. We get them operated on fairly quickly. So in conclusion, I think classification schemes are discordant. We lack a common language. That's too bad. Valve resuspension, resecting all of the ascending aorta with an open distal anastomosis remains the default operation, and transfer to comprehensive aortic centers is reasonable. There are a couple of your friends around the world. Dr. Miller asked to pass on some messages to you. So this is Carlos Mestris. Pass my best regards and hugs to Craig next week at this farewell event. I've known him since 1980, and he's always supported me at the highest level. He's a gentleman and a scholar, and has produced enormous amounts of scientific wealth to our community. Here's Jose Pomar. Unfortunately, we'll not be joining your friends. So wonderful, so deserved day. But be sure I'll always consider you one of my best friends, since in part whatever I did in life was thanks to your support. And this is where I'm not sure what slide's going to show up here. Let's see what happened. Okay, good. So it was a good slide. All right. Reflecting back, my last child, my daughter, was born in Stanford Hospital, and this year she's graduating from high school. So it's been a solid 17 years since I've trained here, and time definitely flies quickly, but the memories will never fade. Thank you very much.
Good afternoon. Okay, so this is something that Mark Moon and I came up with, something a little different, part of your after lunch dessert entertainment. So we've had a leadership session. We had 2 scientific sessions on aortic valve and aorta. We have some mitral and multi-valve stuff to talk about in a little bit. We wanted to change gears during lunchtime and really talk about the career of this gentleman and maybe a few other things. So we're going to have a little fireside chat. We don't have a little fireplace here, but it's sort of the same idea. So we changed seats for this mode. So I asked Mark Moon to sort of lead off this session.
Oh, I thought you were going to lead it off.
I just did. I just gave the intro.
Well, let's just start from the beginning. Dr. Miller, you were not actually born on a farm, or how did you end up becoming a cowboy? Ranch, whatever it was. Yeah. See, I'm from Detroit. Ranch.
Born at Stanford Lane Hospital in San Francisco.
Excellent.
And my dad was doing his residency and lived on Vermont Street. I remember that, which is where 101 goes through now. It's Portero Hill bad area. And the salary, I think he was $25 a month was his salary as a house officer. And you got laundry and food. So that's where it all started. And then he went in the Korean War, in the Navy Medical Corps with the 1st Marine Corps Division, Chosin Reservoir in 1950. Some of you are old enough to remember back then. Not a good place to be, minus 40 Fahrenheit, which by the way is equal to minus 40 Celsius. Not a good place to be. And while he was gone, we'd moved, my mom had moved the family. There was 4 and then 5 of us into Los Altos. And I remember as a 9-year-old kid, nothing but cherry and apricot trees between Palo Alto and San Jose for early 50s. And then in 1955, we moved up north, 250 miles north, because it was too crowded in Palo Alto for my dad. And he had grown up in Palo Alto in the 20s and 30s, shooting ducks where the Palo Alto airport is now, shooting pheasants where the VA is now. And so from that background, he said, there's too many people when it was all trees. And the worst mistake he ever made in his life, and we don't know the magnitude of the mistake, is in 1955, he sold a big house on 5 acres of land on Atherton Avenue for who knows how much money. And I don't think he ever wanted to realize the magnitude of that error, but moved up to Reading. And his grandfather, my grandfather, his father had a ranch on the Oregon border, which he had spent time at as a kid. And during the 60s, some of you remember back that far. Got to look at the age of the audience. There was a TV show on every Sunday night on TV called Bonanza. Any of you remember that?
Hoss,
Big Hoss, and Ben Cartwright, and it was filmed at Tahoe. And so my father somehow got it in his mind that he was Ben Cartwright Jr. and we lived on a small ranch, but had other ranches all over the northern part of the state, Oregon and Nevada. And it's a great way to grow up. And I was lucky because we moved out of town when I was in about 8th grade. My 4 sibs went to the local schoolhouse a few miles outside of town. All four of them, their 8th grade was a single room schoolhouse. And so that's how my sibs got educated early. And I'd gone to town so I could speak English, a few other things before we went to high school. But I remember in a public high school, these teachers were wonderful. And we all know teachers are undervalued, underpaid, underrespected. But here was a public high school with a lot of Mexicans, a lot of Indians, very few African Americans, if any. But these teachers went to the extremes to teach the kids who wanted to learn what they wanted to learn about. I got A's in farm shop.
Was that your favorite class? What was your favorite class?
Probably mathematics. And I
Math?
can remember my high school teachers' names, which is fascinating because I can't remember a whole bunch of other things. But Ron Hedgie in math, and Mr. Heinenton in biology. Math, I really liked for some reason.
That was my favorite class.
And algebra in high school, and then calculus, you could finally see there was an application for all these numbers and how it works. So that's kind of drove me toward a scientific aspiration. But what these high school teachers did was just remarkable. And today, I'm sure it's not the same, and I really worry about the young generations. So anyway, to answer your question, Dad moved the family up north, and we grew up with more horses than brains, for sure, more cattle than brains, and it was a great way to grow up. The value systems you learn, the hard work, the self-reliance, the independence, the resourcefulness, which has been what it takes for all of us in this room to get where we've gotten.
Did you grow your own food?
I had gardens, and I have to actually truck the water from the creek to the tomato and the vegetable plants. I remember as a kid doing a lot of that.
What other chores did you have when you were younger?
Running the cattle and the horses. So that would be pretty much. And then in high school, my brother and I would disappear for 4 weeks up in the mountains with some mule train and the horses when you put the cattle up in the high country for the summer grazing. That teaches you a lot of lessons, and there's no one to turn to if something goes wrong, and there's certainly no phone to call. But it was just hard work, lots of reward. And the value systems I think I learned.
Did you ever think about becoming a rodeo star? You sort of dressed like one.
My dad has so many orthopedic surgery bills for all the kids in junior rodeo and high school rodeo, broken bones left.
So you did?
Yeah.
You did rodeo?
Yeah.
Yeah. Tell us about your rodeo days.
I never was in the money. We started off with the calf riding, and then you went to cow riding, and then you went to the saddle broncs. And my brother and I were team roper, head and the heels, and it was a lot of fun. We weren't very good, but we just had a lot of fun.
So
my sister was a barrel racer.
Is that why you wear a hat and the boots from the rodeo days?
That's the way we grew up.
Okay. All right. We found the origin of the hat.
Yeah.
That's
No,
exactly-
Rodeo.
The funny shoes and the hat, and funny belt buckles. It's just the way you grew up.
How did that go over when you went to Dartmouth?
I was just going to lead into a story about Dartmouth. I was like a fish out of water. Public high school, I think 4 or 5 kids out of 250, 300 went to a 4-year college. College was just not on anybody's radar screen. And I didn't know what a prep school was. Can you imagine ending up in an Ivy League college and not knowing what a prep school was? And I was surrounded by all these pencil necks who had gone to prep schools that I'd never heard of. They were awfully proud of Andover and Eaton. And
Did you know the sequence of utensils?
No, and I still don't today. But I got in a little trouble there because I don't think I was obtrusive, but I knew what was right and I knew what I wanted. So there were some fisticuffs and a few little fights here and there. And I went into the associate dean for freshmen getting hauled up on some charges. I've forgotten what, but and I said his name was Albert Dickinson. Why I remember that, I have no idea, but I thought they were going to throw me out. This was it. And I said, Dr. Dickinson, I just don't understand why you're making such a big deal of this. I grew up fighting Indians and Mexicans. And the dean had a pipe in those days, and he nearly choked on his pipe. And what's that? Yeah, I was DEI for sure. The only reason I got into that school was geographic diversity, public high school and geographic diversity. I'm sure that's the only reason I got in. Stanford.
What did you
turned me
major?
down. Physics, chemistry, and mathematics.
Can you tell the story about, I met one of your friends long ago. He used to drive across country to Dartmouth. And he relayed, and I don't know if it's urban legend, but as you were crossing the Mississippi River one day in St. Louis, you did an experiment or did something, I'm not sure.
And a 68, no, 66 Ford Fairlane with a big 390 V8, go fast car. And we'd make it from the West Coast to New Hampshire in 48 hours, picking up people in Denver and Cheyenne and whatnot, looking at Robbin from Cheyenne. So we knew I-80 well. And we'd only stop for major bathroom breaks and to buy more beer. But 48 hours
Beer for the driver.
Day and night. Well, the most sober got the driver's position. And we'd be real careful in Nebraska because the cops were in the cornfields and they would stop you and you'd have to pay in cash before they let you out of the county. But we made a couple errors. We'd go up through Detroit, where Mark's from, and across into Windsor and cut across the bottom of Ontario to come back in at Buffalo, Niagara Falls. And of course, we had some arms with us and some ammunition and some dynamite and toys for the boys. But can you imagine crossing the border today with that in your trunk? So the story that you recall from whoever told you this is true. It was Bruce Hamilton, maybe. It was Dubuque, Iowa. And there was a big Dartmouth alum there who loved to have all the guys come through when they were driving through and had a lot of pretty girls and it was a good time on the river there. But one trip, one is either June or August, one way or the other, he was complaining that somebody had built a water ski jump where they like to do their slalom skiing. And he said, I've talked to them and they're nice folks, but they think it's their water and this. And they said, well, I think we can take care of that. So in the middle of the night, we're in a boat rocking and we had about 5 or 6 sticks of dynamite. I'd forgotten the blasting caps. You need a blasting cap to put the fuse in to stick in the dynamite to make it go off. So we were kind of out of luck until we figured, oh, we got a couple pistols. So we're in this rocking boat shooting at a bundle of dynamite sticks, drunk as a skunk with the pistols. And finally someone hit it. And this water ski jump went up and up at about 500 yards. And then we got out of Iowa real quick. And
I remember you shared a story with me on one of our houseboat adventures about a pickup truck with people in the back, sort of brandishing certain things. And there was a certain fellow that was there that went on to be in the Clinton administration. He was a short fellow, he had to stand on the boxes and talk. Remember him? And
yeah,
you guys had
Clinton Secretary of Commerce.
Yeah, right.
What? No, a little short guy.
Yeah, right.
Right.
Yeah, Reich. Yeah. Didn't you
Not
have some
Reich.
form of
Bruce Reich?
No, Reich.
Yeah, he's a professor at Berkeley. He's a communist. He's a Marxist now, and he was then. And he started SDS. Now, not many of you are old enough to remember what SDS Sierra Delta Sierra, SDS, Students for Democratic Society. That started in about 66, 67. And it was when all the colleges were protesting the Vietnam War and trying to shut down the colleges. In Kent State was where someone got killed, unfortunately. But Robert Reich, R-E-I-C-H. He was a little short guy. And he started that. And we, on the other fringe, had a group named Loft. Least not forget your traditions, or something like that. And it was in the middle of the winter, about -10, and it was snowing, and they were having a protest and a rally at the student center, and they were on a balcony. I think this is the story you're getting at. They were on a balcony, and everyone had winter coats on, and we had discovered a way that we were going to end this protest quickly. We had some 30 caliber carbine bullets. We took the bullet out, and liquid wax was put in its stead. So it's not going to kill you. But when it hits you, you sure feel it. You feel it stings. And we had a pickup truck we had borrowed, stole some plates in Vermont, put the false plates on, and drove slowly along where this protest was. And then 3 or 4 guys in the back of the pickup truck get up with these 30 caliber carbines, bang, 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 bang. And they thought they'd been hit. They had heavy coats on, but they could feel it sting and all. And boy, did that old pickup truck zoom across the Connecticut River back into Vermont and hide forever. Yeah, politically, Robert Reich and I did not agree. But when he was Secretary of Commerce, Commerce for Clinton, I saw him on a TV once, and he said, I don't know why all these people complain when they're government employees that they can't fly business class or first class. And the guy's as short as a pygmy. And that's why he didn't mind flying in coach on a government ticket. Now he's a distinguished professor at UC Berkeley.
All right, I have a question about a college activity that does not involve guns or high explosives. You played football.
Yeah.
Tell us about your football days. Did the rodeo help?
Being raised outside of Reading helped. No, we thought we were pretty good. We obviously weren't.
What position?
Defensive halfback. 210 pounds. So all muscle then. It's all fat now. But I was pretty fast. And it was good team, good times. The last I remember, no, it's actually it was my last year I played in 67. You've all heard of the Yale Bowl. Those of you from the East Coast certainly have. Huge, big, 80, 90,000 fancy bowl. And we were playing Yale. And I was a defensive halfback, and a guy named Calvin Hill. Calvin Hill was the running back for Yale. And he was built monster guy. So Calvin Hill and I collided. I had the speed, the velocity. He had the mass. And they carted us both out of the stadium on stretchers.
Yeah.
And he went on to play for the Dallas Cowboys for 10 or 15 years.
V squared wins. So did you ever catch an interception?
Yeah.
Yeah. Pick six?
Can't remember back that far.
Okay.
Yeah, if you did, you'd remember that one.
In the winter, we had the alpine skiing, and that was fun, except skiing in New England, when you're raised in the West, well, it's a joke. You're skiing on ice skates, Anyway, we did that. And then in the spring, the first year I rode, I didn't know, I thought a shell was a shell of an animal. And I learned what an 8-man shell was with the freshman heavyweight rowing team. There's 8 guys, and you go out there and beat your heads and your bodies into the ground, and then say you're having a good time. The Nordic skiers and the rowers are the 2 most masochistic group of persons you'll ever meet, because you go out there and try and kill yourself and then laugh about it. But that
Sounds
was
like your OR days.
That was fun. But the football was fun. The rugby was more fun because we'd go to places like Bermuda, And then that was a lot of fun. And yeah, after a rugby, after the pitch, you all drank beer. And so that was a good days.
So I presume you had no idea about heart surgery when you went off to Dartmouth. Where did that come from?
When I got here in June of 1968. And that was 6 months after January 6th, 1968. And this transplant thing was pretty hot. And there was this frumpy dressed man named Norman Shumway, who even as freshman medical students, he would come and talk to you and inspire you. So I thought that was pretty cool stuff. And physiology, mathematics, that kind of, you might ask, well, why did I get into medical school? I don't know why I got in, as a matter of fact, but why was I interested in medical school? It was because in chemistry and math, you get up into seventh dimensional statistics and it gets really dry. And I said, this is sterile and I need a little more human interaction. So that's what then led me to pivot into medicine.
Your father have any influence on that?
No, he didn't guide us, any of the kids. He did, my mom and dad, they didn't push us, but they had high expectations. Probably unlike an Asian family.
So you had a tiger mom also.
What's that?
You had a tiger mom.
But they expected a lot and we did a lot. And I was always eager to learn, thirsty to learn.
Did you find it hard to memorize all those things in medical school? If you liked math and chemistry and physics so much?
No, you just had to do it, you know. And then I learned how to bullshit my way through medical school. And that is, there's a whole dictionary of eponymic medicine. So you learn all the eponyms and you sound like you know what you're talking about.
So tell us about your first interactions in medical school when you went into the hospital and started meeting patients. I think most of us who went to medical school really remember finally getting out of the classroom and putting on your white coat and then going and meeting patients. Tell us about what it was like back then, what you experienced.
It was scary. Medical school classmate cardiac surgeon is here. Bob Allen, where are you? Stand up from Sacramento. Where is Bob? There he is. So I think we're the oldest Stanford medical students.
You guys were classmates?
Yeah, medical school.
Did you guys shoot anything?
No, but he went to Yale, so he had this polished veneer, you know, and he's from San Mateo, California. My dad and Bob's dad were Stanford medical students in the 40s.
Hey, Craig, I may be able to enlighten the group about how we got into medical school. And I don't know that this is true, but it was always my impression that every member of the medical school class was Phi Beta Kappa, with 3 exceptions. And we all had one thing in common. Our fathers all went to Stanford Medical School. So nepotism was great for me.
Legacy admissions are now verboten.
But you skipped over one thing. Craig and I graduated from high school the same year, and he went off to Dartmouth, but he never graduated from Dartmouth because he spent a year in Europe, as I recall, on the US ski team, sort of the one level below the World Cup level. But I mean, Craig could do anything. He was really a phenomenon when he arrived. The first time I ever saw him, he was doing wheelies on his motorcycle out behind the physiology lab. And I said, what is that? And they said, oh, that's Craig Miller. And he had the Captain America helmet. And there was, no girl that didn't want to meet Craig. So, and none of my classmates who were male who didn't want to emulate Craig. He had an amazing following of people. He had, and the thing about Craig is he's nice to everybody. So, he acknowledges everybody. If you meet him, he remembers your name. he was a fantastic model for everybody. So he didn't just do the classwork. He worked in David Glick's lab, right? Doing nuclear medicine. I mean, Craig is so multidimensional that we get focused on his cowboy hat, but there's that's just a little icing on the top. I mean, there's so much more to Craig that I think we all appreciate. So it was a privilege to be a classmate with Craig. I'm very proud of that.
I'm glad we're both still upright, and able to remember those days. Not all of those days, though. Thank you, Bob.
Well, okay, so we're working our way through medical school, and had you already decided you wanted to be a heart surgeon, or did you actually entertain other fields as you rotated on those clerkships?
I think we were all mesmerized, but to some extent, by Dr. Shumway and transplant, and the success and the characters and the personalities of the younger cardiac surgery team, from the residents to the junior faculty, Tom Fogarty, Pat Daly. They kind of that stimulated anybody. So we were drawn there, but in those days, there wasn't such a thing as cardiac surgery residency or general. And with Harry Oberhelman and Dr. Shumway's Maverick or Outlaw School, as you all know, you could do a little this, a little that, come back, do a little cardiac. If you liked it, then you could go back and come back. And Dr. Oyer and Dr. Wright, who I think are both in the room, finished their general surgery rotations after they had finished their cardiac surgery rotations. Maybe Bill Baumgartner too, you finished after the cardiac. Those were the days. And so it was pretty flexible and floppy, and they let us auto engineer it to a great extent. I don't know why Dr. Shumway accepted me for training, except that Randy Greep, Tom Fogarty and his new private group in 1971, they had left Stanford and gone up the hill. But there was a bitter vendetta for beds, basically because it was just no beds. And Dr. Shumway, there was a private hospital then, it still is legally today, community and faculty. And the community, for some reason, got an allocation of beds, which was greater than the full-time faculty. So when Tom was on the faculty and Pat, Dr. Shumway got the not so wise idea to make them community faculty. And they had an office right across the street on Welch Road. But because they were community, even though they were on the same residence, same everything, we got more OR time, we got more ICU beds. And so it helped the system expand until Dr. Shumway saw all the money also going across the street. And then he realized that hadn't been such a wise strategic move. But these were the great days of being a student and a cardiac surgery resident.
Was that was your training sort of the stimulation behind you pushing to build an I6 program? Because it was your idea, I think, wasn't it?
Yeah, only as a historical person who could vouch for it. Bobby and Mike Fishbein are the ones who made it happen legally.
Mm-hmm.
It was really an outlaw maverick, great way to do it. Everyone got boards except for a few who will remain nameless. But it became quite hard to get boards if you trained in this maverick school.
Mm-hmm.
Tom Fogarty once took a case of Jack Daniels whiskey over to Dave Dugan in Oakland. Dugan was head of the American Board of Thoracic Surgery then. That's a true story.
Did it work?
Yeah, he was allowed to take the boards and he passed. But it was the same Tom Fogarty who was, I guess I was a young resident, I can't remember. And he was, even in those days, going to meetings, giving talks, the same Tom. But he got on the wrong plane in San Francisco and woke up when the plane got to wherever it got to, and he was in the wrong airport. He'd gotten on the wrong plane, Tom Fogarty.
That's why he flies himself now.
So when you were president of the AATS, we heard about your talk you gave, or sort of our interpretation of it, the Ente Memoirs of Rocinante. What was that? How'd you come up with that? What was that supposed to mean to you, and what was that supposed to mean to us?
Well, anti-memoirs came from Andre Malraux, who wrote that book in the 1920s about the first communist insurrection in southern China. He was French, and I did not read it in French, but I read it in English. Man's Fate, I think was the name in English. And Anti-Memoirs, his memoirs was entitled Anti-Memoirs because he didn't want himself to be the subject of attention. He wanted what he was talking about, the poverty and the health problems in China under the fascist system, which the communists had tried to overturn and failed in the 20s. So anti-memoirs came from that. Don't put yourself up front. And all day long, you're hearing a lot of attributes about Dr. Shumway, and this is really one of the greatest. He never wanted himself to be up front. As Stuart Jameson used to tell me with regularity, only one person rides in front of the camel, and that's not you. You're riding it back.
Why a camel?
Because Stuart's from South Africa, Zimbabwe, and he had camels, I guess.
And no rodeos with camels.
No, but Dr. Shumway always put the team and the people who did the work ahead of his own self-aggrandizement. So that's anti-memoirs. Rocinante and Kiko Nastal from Santander, Spain is here today, coming all the way from Spain just for this. Kiko told me that the word rocin, R-O-C-I-N, in Old Spanish meant, and Cervantes was what, 1605, 1606. But rocin was the old Spanish word for a broken down nag, a horse you couldn't sell and you couldn't give away. So Cervantes in the Don Quixote style is Rocinante, making it glamorous and gorgeous and fancy. And so Rocinante was the horse of Pancho Sanza. No, of Pancho Sanza walked. Yeah.
It's a skinny, bad horse. So,
And you can still see, if you locally, you can still see Rocinante. Now the horse is long dead, like 4 or 5 centuries ago. But everyone remember John Steinbeck, American novelist who won a Nobel Prize. He was born and raised in Salinas. And in late 50s, early 60s, he drove across the country in a GMC pickup truck. And he named that pickup truck Rocinante after Don Quixote. And it's in a museum in Salinas today, 100 miles south of here.
You can still see the windmills also.
Yeah.
Okay, so people in the audience probably don't know this, but for the 100th anniversary of the AATS, Mark Moon wrote a landmark textbook. He actually went and interviewed all of the living past presidents. So maybe Mark, you can talk a little bit about what it was like to interview Craig Miller.
you know, it was interesting. I'm not sure why, but he did not wear his cowboy hat during the interview. I'm not sure. When did you decide not to do that or do it? But it sort of, he was one person that he is one of the only people that has not had their presidential address published in the journal. I think you may be the only one. So after you, just like Dr. Shumway, he didn't have his published, but once he passed away,
Sarah and Bruce had
Sarah
to do
Bruce.
it.
So once you pass away, Joe and I will take care of that for you. But we can wait, so there's no rush.
We might go first. So that interview went well?
I thought it was,
insights you're allowed to share
No, I mean, I
that
think
aren't published?
It's
that aren't
not
published.
publicly available, though.
What's that?
It's not publicly available, your book.
No, you can't get it on Amazon, but you know, it's been it's almost 10 years since then. So I think I'll update it.
Well, expose the public to it too.
Yeah, exactly.
Yeah, it was pretty intimate, and a lot of us confessed some pretty secret details of our lives. I'd never learned that Toby Cosgrove was dyslexic until he admitted that in these interviews.
Mm-hmm.
Little tidbits like that. It's fascinating
What was the most interesting thing that happened during your year as AATS president?
We wanted to know what happened to all the bright young trainees that we used to be flooded with. It's kind of like the last election. Where are all the good, strong, visionary candidates that we used to have? But there had been a major recession, but that was 08, 09, I guess. But even before that, Jeff Rich and others, Tim Gardner, your mentor, addressed the problem that there was interest in cardiac surgery was going away fast. And there weren't a lot of jobs. And so we felt Mike Mack, Rick Fines, who you've already heard about. By the way, Dartmouth, a classmate of mine, Rick Fines, who worked with Jim Fann on the ABTS. Rick Fines was the coxswain on that freshman heavyweight crew. So here's this little teeny guy screaming in my face because I was rowing number 8. And Rick went on to a distinguished career in general thoracic surgery. But we realized there was a person power problem and a job problem. And there had been an earlier recession in the late 90s, the dot-com crash. And so the surgeons who should have been retiring were not, because their financial nest egg had been crippled. And we figured we better try and turn this around and turn the ship and make it easier to be trained and make it possible to be trained before you reach 40 years of age. But that again goes back to Dr. Shumway's genius, that catch the people when they're young and creative. The educational psychologists have known for a long, long time, centuries, that your creative processes start to wane at age 20, 25. If you look at the physicists, the musicians, the composers around the world, it's starting to lose it at 25. And then your creative processes take over. So you're much more productive, but less creative. So we had to get the young people and do what we could to make them finish, hang out their shingle before they're 40.
Well, Mark listened to your words and has created a series of scholarships inside of the AATS to attract medical students. So very early on, so to go into cardiac surgery. So someone's listening to you.
I'm still not sure the jury's not backed with the verdict. It's still going to be a few more years. Whether the I6 is training equally good surgeons as the older traditional programs. There's certainly been more interest. So I guess that's the first step of success.
Well, I think, this is a credit to Bobby Robbins and Mike Fishbein creating the nation's first I6. But since you created it till now, the transformation is unbelievable in terms of nationally. I6 programs have the highest board scores. Cardiac I6, cardiothoracic I6 applicants have the highest board scores of all of the subspecialties, so higher than dermatology, radiology, et cetera. So it's, I don't know all of the quantitative metrics, but there are arguments now that I6 CT surgery is perhaps the hardest residency to get into from medical school.
That's fascinating. I thought the bright kids would have been going to dermatology and urology and ophthalmology. Work-life balance.
Did you have work-life balance?
No. None of us did. None of us did, but we were on top of the world. And we were learning all the time. And we were given leeway to learn the hard way sometimes. But just learning. It was just exhilarating and stimulating and almost like a Japanese kamikaze pilot. But it was wonderful.
What are you going to do now? Are you going to write your own memoirs or anti-memoirs?
Anti-memoirs. Well, the first 2 years, year and a half was easy because I had to take care of some old overdue writing assignments, including the 2 chapters in Savastin on aortic dissection. And Philippe is here, Demers. He had done the first one some 10, 15 years ago and revised it every few years. And then he asked one of his young trainees, Victor Chavette, to update it this time. And to be quite frank, I wasn't happy with it. So now that I'm retired, I spent 1.5 years and redid both chapters from scratch myself. And I've pissed off every pseudo authority and authority in the world on aortic dissection by what I wrote, but they accepted it and it got published. And I think it was good for me. It kept me off the street. I'm not sure it kept me from going crazy. But it was a good academic exercise, and I had time to figure out what I'm going to do. And so now I'm there, that's done. A few other things are done. And now I'm just not sure what I'm going to do. I still, my middle name is Polemics. Polemics. I love to throw hand grenades, live hand grenades into campfires and stir the pot. And I still love to do that. Robbin knows, and Pat knows, Jeff Rich knows from how are we going to police our own regulations, the national coverage decision, NCD for TAVR, NCD for MitraClip, TEER, and they're being widely ignored and abused, and the whole thing has fallen through because there's no one there to police it from the ethical side and enforce it. So there, I would love to jump in with some heavy artillery, but I'm old, I'm retired, I'm not supposed to be a combatant anymore. But I still think we need the hand on the helm to guide our specialty in the right direction to maintain what we all signed up for, and that is a noble calling to take care of sick folks and their families, which I'm afraid is vanishing. Fred Loop told us in the 1990s, Fred Loop from the Cleveland Clinic, we have given away the store to the money changers. And in corporate medicine in this country that we see today, the non-Americans here are blessed not to have to put up with this. And it's a difficult time if you still just want to take care of sick folks and their families. But that's why we're here.
Well, any last words of advice to the next generation?
Not really, just work hard, keep your head down, keep your mouth shut if you can. Don't be like some people we know. And it is inspiring to see the young people still interested. And it's absolutely overwhelming. I mean, it's touching, it's warm, heartwarming. It's overwhelming to see this group with this people and going back decades. And it makes it all worthwhile. So I'll end the way I ended in Toronto. We kind of did this before. And I'm not sure if I got this from Dr. Shumway or not. It might be original. But and Dr. Shumway would started it off, but he says, what are you going to be remembered for, known for, famous for? What are you going to be most remembered for 100 years from now? It's not going to be the number of cases you did. It's not going to be the amount of money you made. It's not going to be the number of alimony checks you write each month. It's going to be how your trainees, what they do. And that's what makes me so incredibly proud of all of you. And it made it worthwhile.
Thank you so much. We're going to go right into the next session on mitral valve disease. Our next speaker, Dr. Pat McCarthy, former chief at Northwestern and graduate of the Stanford Fellowship, was not able to take off. He was on a runway and the plane went back to the gate. And so he was not able to join us. He did take the time to record his talk. And so we're going to play that video, and then Chris Malazri is going to serve as the panel discussant.
Good afternoon, everyone. Unfortunately, the bomb cyclone and then the winter storm in Chicago conspired to keep me from being there because I've been looking forward to this for 6 weeks. They've asked me to talk about the trials of transcatheter mitral repair versus surgical repair. But before I do that, I'm going to say just a bit about Dr. Shumway, one of my inspirations. It was exactly 25 years ago. It was November of '89 when Bobby Robbins tells me that he did his last heart transplant with me. That's Bobby, Tom Flavin, and then Garrett Tobler watching while we did that. It was another day that was like a bomb cyclone in Stanford. He couldn't go golfing. The donor heart was due back at about 11 that morning. And so I was able to talk him into it, and it made for a memorable day. Somehow someone had a Polaroid camera to capture it. So I'm going to talk about mitral repair and TEER. So first of all, just to set the stage, mitral repair, as we know, is the safest, most successful adult cardiac operation almost ever. So why do we want to compare this to TEER? Well, a couple of things. One is it's undertreated. A lot of the patients are in their late 70s, and they're never even referred to surgeons. This is a report on the left side from earlier this year showing that only 29% of the patients with primary MR were being sent to the multidisciplinary team. And on the right is a Mayo Clinic article from 2018, and interestingly, exactly the same, 29% of the patients were being treated with surgery. There's also studies from the University of Michigan and from France. Basically, as surgeons, there's a lot of these that are not sending us because they think it's just too invasive. The other is that there have been over 200,000 MitraClip implants now over the years, and it's getting better. The results on the left are not even as good as they are these days with the Expand registry report that's coming out. But also our surgery results maybe aren't as perfect as we like to think. This is the tricuspid study that was done. This is looking at the mitral results of repair. And there's a pretty good amount of mild and sometimes moderate MR after repair. So there's not been a randomized clinical trial of surgical repair for quite a while. It's time to take a better look at it. This is an overview of the repair MR trial. I'm PI along with Saibal Kar. It is going to look at patients like partner 2. They have severe primary MR. They have to be 75 years or older, or they're at moderate surgical risk, and is thought to be repairable by the surgeons and also by the transcatheter team. 500 people, up to 60 sites in the US and in Europe. It's a prospective randomized trial. It is a non-inferiority trial. We're looking to see if MitraClip can be as equivalent of safety and efficacy as surgery. What are we looking for with this? Well, the high-risk commercial group are already approved. We're not interested in that group. There are already, some uses in selected patients, as we'll talk about a little later. Also, we are not looking at the low-risk group of patients that currently undergo surgery. The average age in most surgical series is about 60 years old today. We're not interested in that group. This is more like a sliver of the patients. We estimate at Northwestern it's about 10% of the patients that we see are either 75 or greater or have something that makes them at moderate risk. So what is moderate risk? It is different from TAVR studies. So if you look at this report from 2019 for mortality, what we're finding is that the 75th percentile is 1.2% predictive risk of mortality in the trial so far, and we're about 75% enrolled. Our average STS risk is running about 1.8. So this is, in fact, a pretty sick group of patients, probably in the top 5 to 10% of patients that we would be operating on. There's a safety and an effectiveness endpoint. The safety is the usual suspects: mortality, stroke, cardiac hospitalization, or acute kidney injury requiring renal replacement therapy. It's a 2-year endpoint. Notably, any cardiac hospitalization in the first 30 days post-treatment is excluded, so patients go home and have AFib 3 days later, or that have a pleural effusion. Those are not going to be counted against the surgeons. The effectiveness endpoint had a lot of discussion in the surgical community. This is the proportion of patients with moderate or less MR without a mitral replacement. So if a patient goes on and needs their valve replaced, or even at the primary operation, or recurrent MR intervention, such as they may 6 months later or a year later need a TEER, those are considered failures. The secondary endpoints are looking at the group with less than mild at 30 days among survivors, hospital length of stay, those discharged to home in this elderly group of patients, and of course, KCCQ. Also symptomatic mitral stenosis patients. This is going to go on for 10 years. This is not just a quick look at the data. Every year we'll be gathering follow-up information on these patients. One of the controversies with the surgeons was the importance of just plain moderate MR. If there's more than moderate, they're a failure. If they are mild, they're a success. Some of the surgeons wanted moderate to be a failure. It is not clear that just an echo finding of moderate without the clinical endpoints that I talked about is a failure. So we're going to carve that out. We'll be looking at it in the two different groups at the 2-year endpoint and then periodically as needed during the follow-up. But making it a primary endpoint like death, stroke, or reoperation just does not appear to be warranted from the data. And we have an abstract that's going to AATS that looks like it would support that. There's also a CTS net trial. It's called the primary trial. They're trying to prove that surgery is better than TEER, so it's not a non-inferiority trial. They are randomizing patients down to age 60, and they are also randomizing patients that are elderly and that are commercial, so they could be randomizing an 84-year-old patient with a reoperation. And they're using both devices, both MitraClip and Pascal. If you look at this, though, they're only randomizing 450 patients. And when you look at the partner trials and the Evolute trials and all, they randomize 6,500 patients to look at the same type of subjects. So what we're worried about with this is that what if with only 450 patients, statistically, there's no difference in the outcomes? I think we're all concerned about how the interventional cardiologist may interpret that and say that, well, the results look the same between surgery and with TEER, when that may not be true whatsoever. In addition, the surgical patients, remember, you can treat concomitantly AFib with an ablation, which is known to improve survival. You can close the appendage. You should close the appendage to decrease the risk for a stroke. And you can treat moderate TR. If they have more than moderate, they're going to go, they're not in the trial. So there's reasons to think that surgery may actually look better than TEER in this group of patients. So do we need the primary trial because TEER is so common in the low risk patients? Well, not at Northwestern. Our average age is over 81. Most of these patients have frailty. They're New York Heart Class 3 or 4, lots of prior cardiac surgery. Despite this, they actually did pretty well with a 30-day mortality of only 2%. So it does appear that we, at least in the Midwest, are a whole lot more conservative. And I know in California, it sounds like they're doing a lot more of this. So the evidence gaps, we're trying to make this crystal clear with repair. We're going to be able to do long-term trials and studies, I should say, in this group of patients. And we're worried that primary may muddy the water because it's not powered enough to really prove necessarily that surgery is better. So finally, a word about Craig. I'm sorry I can't be there, Craig. You were one of my mentors, in particular in mitral surgery. I liked this one about sizing with Voodoo. People would hold those sizers up and then roll them around and then say it's size 32 or 36. They just made it up. And what you had asked for in this paper was a more scientific and reproducible strategy of ring sizing. And we think we have that. We published the algorithm during the pandemic. And I know Chris Malazar will be there, and hopefully he'll be able to speak to it a little bit. So I hope that you all enjoy the rest of your day, and I'm sorry that I'm not able to be there, and instead I'm just fighting this storm that we have whistling outside. See ya.
Okay, we'd like to invite Hermann Reichensperner to come to the podium. Hermann is an expert mitral among many other types of surgery, but will teach us a little bit about 3D endoscopic mitral valve surgery.
Yeah, thank you very much. Thank you very much. First, it's a big honor for me to be here. Thanks for the invitation. I marked it in my calendar that I will not miss that event. Yeah, it's great to be here. So I'm from Hamburg in Germany, which is close to the Danish border, close to the Atlantic Ocean, and the weather is usually like what you see outside. Did I get interested in mitral surgery? I was a transplant fellow here at Stanford in the mid-90s, but I was always speaking into Craig's lab and very interested in what they did. And there was also for a time I actually had a girlfriend which worked in Craig's lab, so that got me fascinated in mitral valve surgery. Now the standard access, when I was trained as a young fellow in Munich, I was always wondering, because we were 4 people on the table, and I did mitral valve surgery, and you almost didn't see the mitral valve. I mean, I stood next to the surgeon and I never could see the mitral valve. So then later on, people got interested in what's called minimally invasive surgery. And now minimally invasive surgery is a very broad expression, actually. So people came up with this partial lower sternotomy, which might look nice, particularly for the ladies if they want to have here the blues open or whatever, but it didn't really work very well. And I think the breakthrough, I must really say, for any kind of small access cardiac surgery was done here in the mid-90s. John Stevens was one of the main guys here involved in this developing of this endo-CPB system. And we did the first cases here when I was here, because the residents who were here were not really interested. So I got the chance to join those cases, and Tom Burton might know better than I do. But one of the first cases we did was a port access mid-cap. And it took all day. Finally, they had to take him back in the middle of the night and do a sternotomy and redo. I don't remember if it was bleeding or whether it was the anastomosis, but Dr. Shamway actually made rounds on North ICU the next day, and he came past this patient and he said, I don't know about these minimally invasive patients. They look like any other patient, because of course he had this scar. So that was the start. And but I must say it was a very smart system. You had the endo-aortic balloon, which is still used these days particularly for redo cases. You had this specific femoral cannula where you insert the intra-aortic balloon. It had a coronary sinus catheter. It had a pulmonary vent catheter, all in one system. So it's a very smart, thought-through system. It also made it to the Financial Times on front page one day. Some pioneers then took it over also in Europe, and Fred Moore, a friend of mine, many of you know from Leipzig, and Hugo van Ermen from Belgium, were really instrumental in moving this technique forward. And when I went back from Stanford, I first went to Dresden, then to Munich. We did the first cases also in what's called mini mitral. And for the first mini mitral, we had Mario Pompili coming over and help us with the first mini mitral, which also took all day. And at the end, he said, how the hell did I get into this? I told him, he's here among us. So, but of course, there's always a way to go. You have to follow the path and develop it further. That's how we started. Of course, using a mini thoracotomy here, a rib spreading. Then we did a femoral cut down for peripheral arterial and venous cannulation. And then another breakthrough, one must honestly say, was Reni Chitwood, because Reni Chitwood came out and said, I'm not so happy with this balloon. It takes me ages to do the balloon. So he developed with a instrument company the so-called Titwood clamp, which revolutionized minimal invasive mitral valve surgery. It was so much easier, of course, to use it without the balloon. Then endoscopy came into the game, and 2D is very difficult in mitral valve surgery. If you use a two-dimensional microscope, you don't have the depth perception you need. So companies came up with different 3D endoscopes. There was the Vista system, and that's how the results looked like. So it was pretty good already, we thought at that time. And then the robots came in the mid to end 90s. We also got involved in the robotic system. There was a Zeus system by a company called Computer Motion down in Santa Barbara, and of course Intuitive Surgical. And the first cases were done using a robot. Alain Carpentier's group, particularly Didier Lomé, was very instrumental in putting the robot into mitral valve surgery. We also in Hamburg used the Intuitive Surgical robot for basic, already almost endoscopic mitral valve surgery. I think the real breakthrough came with better imagination with 3D endoscopes. We wanted to get away from rib spreading, because I always thought that rib spreading causes pain, and maybe there's a better way. So we just these days just use the so-called soft tissue retractor in the true intercostal space, use a 3D endoscope. And then, so we started that. Tobias Doelger was in the group who is working at UCSF these days, also here today. And we found that this was really leading to shorter hospitalization and less pain for the patients. And it's also fun for the students. They like it. You know, they don't have popcorn, but otherwise they enjoy the 3D view. And finally, you have the depth perception which you need for a successful mitral valve repair if you go to the subvalvular apparatus. Now, I'm not talking about the different techniques of mitral valve repair. All of you know that. I did my first mitral valve repair here at Stanford, assisted by Bruce Wrights in the mid-90s. I'm very grateful. So this is a nipple cut incision here, just around the nipple. In a male, of course, we would use a submammary incision in the women. And then you have the soft tissue retractor. Here we use a percutaneous femoral cannulation like we do for TAVR procedures. So it's not a cut down. We don't want any lymphatic fistulas. Then you have your 3D endoscope here and then you have a beautiful, these days, 2D here reflection. Here's the phrenic nerve, here's the pericardium, and you have this beautiful direct access of the mitral valve, and you can reconstruct the mitral valve. So it's really makes in my eyes a big difference. And you test the valve and you get hopefully a successful repair in this, and this is the result after the mitral valve repair. So there's another talk today about functional MR, so I won't talk much about functional remark, but as we learned from Craig and his team in the lab, that if you look at functional MR, you have also to look at the subvalvular apparatus. The tenting of the mitral leaflets are very important. It's not enough for a functional MR just to do an annuloplasty. Wouldn't work on the long run. You have to tackle the subvalvular apparatus. There are different techniques which are used. We use here Gore-Tex sutures around the posterior papillary muscle. I show you a little video on that, is that we first put these 2O Gore-Tex sutures around the posterior papillary muscle, insert them through the ring to the outside, and then basically we fill it with water, and when you tie it, it brings, you see nicely, it brings the posterior leaflet up. And I think that's crucial to avoid tenting of the mitral valve. So I think for a successful repair for functional MR, you have to address the subvalvular apparatus. And I just show you how it's done here. You see how nicely it comes up. You will see in a minute. Brings really nicely the leaflet up. So we are doing about 120 of those cases a year, and our results are, I think, not so bad, particularly the longevity. This is Barlow's disease. So this is really complex Barlow's disease with anterior prolapse and posterior prolapse. And these are the 10-year results, which we just submitted now for the German Congress this year, with excellent durability of the repair, much more than over 95%. Of course, the long-term results, we know that from Alain Carpentier's publications and Tyron David's publication, 10 years results are excellent. And these are the results. This is for female patients and for male patients. So I think it's pretty good results. There, in Germany, we do about close to 60% in a minimally invasive fashion. They are not all done endoscopically, but at least they are avoiding sternotomy. You can combine it. We've heard from Pat McCarthy how important it is to do atrial ablation as well as the closure of the LA appendage, but you can beautifully do that also with this endoscopic approach. There's no additional incision or whatever necessary. We know about the importance of concomitant tricuspid surgery, which you can also do through the same decision. And we usually do that during reperfusion on the beating heart to avoid an AV block. Of course, it's much, first you save a cross-clamp time, second, you avoid post-op AV block. But as we heard from Pat McCarthy, of course, our close and dear friends are closer than they appear. It's a little bit our own fault because we were the first center in Europe using the commercially available mitral clip in 2007. But I must honestly say for older patients, for inoperable patients, it's really a very valid additional technique. We do about 100 of those a year. What worries me a little bit is the increase in TEER volume over the last years. This is US data. That's a bit worrisome because, of course, you have a lot of patients which probably would benefit more from surgery. There's also a trial, the Matterhorn trial, which was now presented on the ESC Congress, comparing for functional MR TEER and surgery. And you have this thing that it was non-inferior in most of the composite endpoints, except of major adverse events. But major adverse events also means a transfusion of equal or more than 2 blood units, which one can discuss about whether that's really serious. However, if you look at the mitral regurgitation data and you compare TEER and surgery, you see that you achieve much better and durable results if you do a surgical repair. So in conclusion, minimally invasive mitral valve surgery originated at Stanford in the mid-90s. Evolution of minimally invasive to endoscopic mitral valve surgery developed over decades, and three-dimensional endoscopic exit should, in my eyes, used for all isolated mitral valve surgery, can be combined with AF ablation, LA closure, and tricuspid valve repair. And TEER for primary MR can be considered in high surgical risk patients, and we await the trials we've just heard of. But all patients with secondary MRs, I think that's right, to discuss them in the heart team and for an individual right decision for each patient. So with having said that, once again, I'm very happy to be here. Craig, thank you very much for all you did for all these fellows. They came because they're grateful to you for your inspiration. When I was a transplant fellow, I got often called because dissections came in addition, and the 2 residents were busy in the ORs, and I had the pleasure to work with Scott and Craig on the aortic dissections. I got some hard times then, I remember that, but I definitely learned a lot. Thank you very much, Craig. I really, I'm very grateful for what you taught us, and thank you very much for your attention.
We're going to ask Masashi Komeda to come and talk a little bit about functional MR and a variety of techniques that he's helped to pioneer.
Thanks, Joe. And Dr. Miller, ladies and gentlemen, I would like to talk about surgery for FMR. And a little more about physiology-based surgery for heart failure. Years ago, Dr. Miller gave me an opportunity to work on FMR, especially its geometric change. We found dislocation of mitral apparatus, both on the ischemic and non-ischemic side. This is a projection view of the geometric change from the surgeon's view. On the left, those with FMR, and on the right, without FMR. both with ischemia of the posterior LV wall. Dr. Miller also gave an opportunity to studying the effects of the preservation direction of papillary muscles. In this study, oblique direction and then anterior, which enhances LV systolic twist, yielded the best results. As an extension of the studies in Stanford in 2008, we first reported the mid-anterior relocation of the papillary muscles, which is Crohn's modification. It yielded enhanced LV systolic function and less tethering of both leaflets. We then reported PHO, papillary heads optimization, improved version of the anterior relocation for both heads of both papillary muscles to ameliorate the posterior leaflet tethering furthermore. It can be done either via mitral valve orifice or aortic valve orifice. After the PHO, we confirmed significant improvement of the tethering of both leaflets as shown on the right panel. After the PHO, as shown on the right panel, relocation sutures can be seen, which is very similar to the natural strut chordae and stress line on the leaflet, as shown on the left panel. We believe that the closer to the nature, the better. We reported that PHO mid-anterior relocation prevented the posterior leaflet tethering as compared to annuloplasty alone. Anterior relocation has been reported to better fix the posterior leaflet tethering than posterior relocation. Sorry, Harman, it's we got a result. I'll talk about the technical aspect of the PHO. First, the relocation via aortic valve orifice. Anterior relocation via aortic valve orifice has been first reported by our friend Langer. It was somewhat for one head of one papillary muscle. We extended it to two heads of each papillary muscle to improve posterior leaflet tethering and to cope with LV global dilatation. This is the endoscopic view of the subvalvular apparatus through the aortic valve orifice. In the dilated LV, papillary muscles are displaced laterally and tough to see, but by just compression from outside, we can see them very well. After placing the Gore-Tex sutures to the papillary heads, we put the sutures to the subaortic curtain toward out of the heart. One trick here is to put the sutures close to the mitral annulus so that there'll be no bleeding at all from the aortic root. So coming out from through the subaortic curtain toward the outside of the heart. And the same thing. The other suture, which is from the anterior papillary heads, will come from the aortic, the left atrial roof toward the outside of the heart. We adjust the tension of the relocation sutures after coming off bypass in the natural condition under monitor of TEE. The tension adjustment is very reproducible since when we pull the sutures, we see less tethering and MR. And when we let the sutures go, the tethering and the regurgitation recovered. When we have an ideal tension, we tie the sutures. After the surgery, on the right panel, mitral tethering and regurgitation is nearly fixed. The patient is doing very well 12 years after the surgery. This patient didn't have annuloplasty. Now let me talk about PHO anterior relocation via mitral valve orifice. Both heads of the posterior papillary muscles are connected by the relocation suture. Similarly, both heads of the anterior papillary muscles are combined by the other suture. Both sutures are ready for relocation. People said that taking out the anterior relocation sutures is more difficult than posterior relocation. Yes, but using a large French eye needle makes it easier. If you take the suture right underneath the annuloplasty suture, you never catch the aortic cusps. Second. Oh, sorry, it doesn't work. Tension control of the relocation suture is easy. When you pull the suture, the leaflet comes up. The leaflet comes up. And when you see some prolapse, that is the right tension. After coming off bypass, the prolapse will be neutralized by the preoperative tethering. PHO anterior relocation can help reverse remodeling in FMR secondary to AR, ischemic MR, and FMR in idiopathic cardiomyopathy. Recently, we did a long-term analysis of the PHO FMR secondary to AR, yielded a late survival comparative to normal general population, which means that the disease and the etiology is entirely fixed. FMR secondary to ischemia showed next best results. In summary, MV repair by PHO anterior relocation improved the geometry of both leaflets, FMR degree, reverse remodeling, and late survival. In relation to FMR and physiology, let me show you another effort, simple LV restoration. We reshaped the dilated LV apex into more conical form, reducing the LV's spherical shape to enhance its geometry and systolic function. Sorry. Sorry, I need help. The mouse doesn't work. Sorry. Oh, this one, okay. In the left panel, prior to surgery, the LV exhibited neonatal type 3 dysfunction. In the right panel, post-surgery, the apex assumed a conical shape, while the main LV body showed functional improvement. 6 years post-operatively, the patient remains in NYHA class 1. Key consideration include the significance of the LV apex. It is a pivotal component of the heart's muscle band. This procedure is straightforward, efficient, and minimally invasive. In summary, the combined approach, apical LV repair and PHO anterior relocation, has led to improvement in its mitral valve function and LV performance. This represents another example of valvular ventricular interaction, as highlighted by Dr. Miller. Dear Dr. Miller, without your guidance, these operations and research endeavors would not have been possible. Thanks for your dedication to saving numerous patients and my career. Congratulations on your remarkable career, and please continue to teach and inspire us. Thank you very much.
Okay, so J.W. MacArthur is one of our graduates. I showed the slide of all the cases he did during his first 6 months. He just came out of the operating room and is here to talk about innovative approaches to patients with complex MAC.
Thanks, Dr. Wu, and thanks for organizing this event today. I really feel honored to be able to speak and take a lot of pride in being trained by Dr. Miller. A lot of late nights reviewing patient cases, and I learned so much from you. So thank you for that. Degenerative mitral stenosis, it's something that as surgeons, I think we can agree that can be scary and maybe even potentially intimidating. The reason for that is largely because of the risks that surround replacing the mitral valve when there is really severe calcific mitral stenosis and MAC. We see it a lot in the elderly, in our patients, and an aging population. We're seeing it more commonly, I believe. Calcific mitral stenosis is a result of calcification of the annulus and at the base of the leaflet. And it can even encroach on the subvalvular apparatus and into the muscle of the left ventricle. It results in narrowing the annulus and rigidity of the leaflets themselves. The prevalence is about 40% in patients older than 65. It's associated with atherosclerosis, end-stage renal disease, and hypertension, and it carries a pretty poor prognosis. The traditional approach to this is just replacing the mitral valve with either a bioprosthetic or a mechanical valve. The concern that a lot of surgeons have, and that I have, is that you can end up with an AV groove disruption, or you can have significant paravalvular leaks or injury to the left circumflex artery. One way to deal with severe mitral annular calcification is to debride the calcification, but I think that you run the risk of the aforementioned terrible events happening in the operating room. There's a 6-fold increase in operative mortality in patients who have severe mitral annular calcification compared to those patients that do not. So what's the role of transcatheter mitral valve replacement in these patients today? Most symptomatic patients with severe mitral stenosis and MAC are not treated due to the high mortality. So there may be an unmet need here in these patients. Over the last 10 years, there's been a great amount of advancement in the transcatheter techniques that are available. And every new meeting you go to, you seem like there's another device that's out there on the market. And these are just a couple of them that you see on the screen here. One of the D there is a device that we've used here at Stanford, and I'll get to that in a little bit. And then the Summit trial, we'll talk about that. That's the Tendyne device. That's a transapical device that can be used in patients with both degenerative MR and MS. There's a MAC arm to that trial. But we felt that the results have been pretty poor with that trial. And quite honestly, to the incision that needed to be made for this procedure was bigger than the incision that we would make for our minimally invasive mitral valve repairs and replacements. So we felt that this device was not ideal. But the Apollo trial is a different story. This is a full transfemoral device, transapical and transeptal approach. This is also not had great outcomes, but I think it's because of the study group and that these patients tend not to do very well due to their underlying disease pathology. This is another Edwards device. We've used the Evoke valve on the transcatheter tricuspid valve replacement side, but the MySend is the same device, but for the mitral side. All these prelim studies kind of have the same results, with the patient population be high STS risk and poor 1-year survival. There's another way to think about this, and that is by using a balloon expandable valve with a transatrial open surgical technique. And it's something that we've used here at Stanford. There's an ongoing trial that's going here called the Citral trial. And again, the 1-year mortality is not great, as you can see here, 38.5% in the transatrial group. But these patients are still out there, they're still symptomatic. And so what do we do with them? And so these are kind of the menu of options that are available. Either a full percutaneous option, there's the hybrid TMVR, that's the open transatrial option, or just a straightforward surgical mitral valve replacement. I think that the heart team discussion is really important in these patients, and to pick the correct option that's available to them. The preoperative planning for these patients, I think, is important to get a CT angiogram to really understand the burden of calcium and the extent of it. And then also for sizing of the valve. If you're doing an open transatrial deployment of a SAPIEN valve, it can really help to choose which size device. That way you're not having to worry about using a balloon to size it in the operating room. It also helps you assess for the risk of LVOT obstruction. And if you have a thick septal muscle, if you're going to have to do a septal myectomy as well. So this is a quick case that we've done here at Stanford. We've done about 20 of these at Stanford. But this was an 80-year-old lady who had increasing shortness of breath. She had pulmonary fibrosis, chronic kidney disease, and diabetes, and had severe mitral stenosis with a gradient of 10 and circumferential MAC. Her ejection fraction was 65%, and she had moderate mitral regurgitation. Her aortomitral continuity was completely calcified, and she was evaluated for the SUMMIT trial, but screen failed, as almost 75% of these patients do, due to neo-LVOT obstruction. And that's the CT scan preoperatively. And her echocardiogram here. You can appreciate that severe MAC, the mitral valve is not really moving at all, and the aortomitral continuity is fixed and calcified. So this is kind of the setup here that we would use for a minimally invasive procedure. These hybrid procedures are amenable to minimally invasive approaches, which I think is pretty nice. So on the back table, we take the SAPIEN valve before it's crimped, and we put a ring of felt around it that acts as the sewing ring for the valve as we deploy it. I'll show you that in a second. This is just a quick video of how we kind of sew it in, just using fluoroproline and run around the base of that, the skirt of the SAPIEN valve. So we put sutures in around the annulus, similar to how you would for a regular mitral valve replacement. And then those sutures will go through the felt that you sew in here. Once this is completed, the valve is crimped over a balloon, as you normally would for a TAVR. So this is, we always start by taking out the anterior leaflet so that we avoid any problems with LVOT. If there's a really small, thick ventricle, I would frequently take out the anterior heads of both papillary muscles just to create some space for the valve. You can see how calcified this anterior leaflet is, and the anterior calcification, which is pretty uncommon to see this for full circumferential calcium. But that actually made the hybrid approach that more attractive for this patient, the degree of calcification that is. And then the sutures will go around annulus if possible. If you can't get the suture through the thick bar of calcium, it's not necessary. You can just anchor it to anything that's you're able to drive the needle through, whether that's just the leaflet or even just atrial muscle. It's not there really for strength. It's just there to lock the valve into place so that it doesn't move, and also to help against paravalvular leak. So this next suture that goes in is actually not fully around the annulus. That's why I included this portion. Is just through the posterior leaflet there at P3 and then going through the atrial muscle that's adjacent to it. So you'll see here shortly, you can see the tip of that needle is not going fully around that calcium bar, and it's not necessary to. Now, once you get all the sutures in place, then using the commander sheath, you put the valve into the ventricle. I stopped using a wire a while ago, but you can use a wire to help guide yourself. I think the wire is at risk for perforating the left ventricle. That's why I stopped using it. The commissures of the sapien valve have been marked so that you don't cause any LVOT obstruction. Can be kind of hard once the valve's crimped to see exactly where those commissures are. So that purple line there marks them. And then the valve's deployed, usually with 2 or 3 extra cc's, just to make sure that you get good apposition to the mitral annulus. And you're really utilizing the calcium that's there to lock in that sapien valve. Sometimes you'll see gaps that are there, and you can actually use extra pieces of felt to put into those gaps to block any paravalvular leak. Didn't have any of those gaps in this case, but that's something that's been well described. And then after the valve is fully deployed, then those sutures that are there that you see get placed through the sewing ring and secured. And that's the result that we get. This patient had an echocardiogram afterwards. And I think the important thing is to remember and remind your cardiac anesthesia team is that the cage of this valve will be sitting against the septum of the LV. And that's okay because those cells are open and blood can flow freely through there. Now, you can absolutely have an LVOT gradient. And so it's important to look for that afterwards. In several patients, we have had that. One patient I had come back with endocarditis. So all those normal things can still happen, but I think that the ease with which you can get this valve deployed does make some of these more difficult cases a little bit more feasible. So in conclusion, patients with severe mitral stenosis and calcific disease such as MAC can be challenging to treat with conventional surgical techniques. And transcatheter technology, although limited currently, I think is continuing to evolve, and we'll probably get to a point in the near future where it overtakes surgery for a lot of these things, especially in older patients. I think the transapical transcatheter approach is something that is going nowhere, and that's because of the problems that happen to the LV apex and also the size of the incision that is necessary to do it. But the fully transfemoral technique for transcatheter is probably the future of this field. And I think because of that, surgeons really need to be a part of the heart team and be a part of the development of this technology. The results from the Citral trial will be really informative and see if we're really making an impact and making things better for our patients. Thank you.
Okay, very innovative. We're going to finish off this session's talks with Mark Moon, talking about concomitant Mays procedure during mitral surgery. Sort of. Okay. You're going to talk about aortic arch replacement.
Exactly.
Yeah. Okay. That's all right.
Well, no, I thought I'd start with this slide, which Dr. Miller probably recognizes at least portions of it. I saw this slide. It was 34 years ago, almost today, 34 years ago. He was a visiting professor. And I saw this and that looks really pretty cool. And then he went on and showed George Saris's study where they detached the cords and put them back on and showed that the contractility came back to normal after putting the cords back on. So based on that, he had a lot of experiments in that, showed pressure volume loops. I think one lecture you gave on pressure volume loops, the other was on, were you saying like cholesterol or something? And You were studying something. Fann was in the lab, but that wasn't the research I wanted to do. Fish oil, that's what it was, fish oil. I found this, it was fun to do at the time, but I found this much more interesting. I wanted to create pressure volume loops. So I went to Gordon Doelger, who was the chief of cardiothoracic at my general surgery program, and asked him if he could pull some strings. He called Dr. Miller, and I went out for an interview. And I went out for the interview maybe in January or something, and it was on a Friday. And he usually didn't operate on Fridays, but he was operating on Friday. And then I met Phoebe, his old assistant, and she said, well, he can't come out. You won't be able to see him. So I went all the way to California to not see Dr. Miller. So what they did was stuck me with Kwok Hyun. And Kwok took me all over the lab and showed me everything. And then it did turn out that I stayed for the conference the next Saturday morning, the combined cardiology and cardiac surgery conference we used to have that Steve Osterley ran. Cardiologists on one side, surgeons on the other. It was pretty fun. But never did the two ever mix. It was weird. But anyway, I did meet Dr. Miller that morning, and he said, Kwok said, you're okay. You can be in the lab. I said, that's great. So Kwok made my career. And so then the next year, I found myself in the lab. I started with Louis Castro, and then Abe DeAnda joined afterwards. And it was a lot of fun. My first paper, though, was what Dr. Mitchell was talking about earlier, where we created the dissections in the aorta, and with Mike Dake, and he came down and we put in stents and whatnot. And that's when Greg said, that's not really science. We got to do something more interesting than that. So we did a lot of mitral valve experiments with Louis Castro. We compared the Carpentier rigid ring to the Duran band. And I remember that he presented that paper in Kauai at the Western. And I remember being in the pool with Dr. Miller and Dr. Carpentier as he was prepping him how to grill Louis during the presentation and ask him good questions. So I carried on, and I got to do 28 mitral valve replacements in the animal lab, which some of the attendings didn't realize I had done that because it really didn't translate into human surgery. But then after I graduated, I went to WashU. And one thing about WashU is it was the home of the Mays procedure, right? And so I had to work my way into the Mays procedure, but I worked my way in through the things I learned with Craig. So first thing I did was we had to figure out how the atrium functioned, right? Because that was what the Mays procedure was all about. And I didn't have the access to use the myocardial markers that Dr. Miller's lab used. So it turns out conductance catheters actually work very well in an amorphous structure in order to give you pressure volume loops. And so I was able to make pressure volume loops, and we extended it to MRI, where we could do tissue tagging and measure minimum and principal strain. And I was at the AHA meeting one year, and Bobby Robbins was sort of giving me advice about how to get FDA funding and R01s. He said, sure, you can get an R01 with function, but you got to drop function. He said, I got one word for you. And I said, what's that? Apoptosis. Apoptosis, I didn't even hardly know what it was. But we did realize we needed to get into some of the molecular mechanisms. So on Bobby's advice, we went into proteomic profiling. You see that second name there, Anson Lee. I didn't actually know who he was when Hamid came up and said, I got to include this guy in the paper, and said, who the hell is that guy? But anyway, I think he was a medical student or something, maybe at the time. And so he got on the paper and he became one of our residents. So the Mays procedure obviously started with Dr. Cox, and it started at WashU. That's where he did all the series of experiments and came up with the Mays 3 procedure in 1995. And it was that year I'm scrubbing with Ed Stinson and Jim Fann. And Jim was very astute at reading the literature. And we're in the middle of the case, and we're doing a hokum. And he says, Dr. Stinson, this patient's got AFib. Should we do a Mays procedure as well? And he said, James. And he never called him James, so he must have been being excessively wanted to make a point. James, you want to know what I think? Yes, I want to know what you think. I think you've lost your mind. So, I mean, it was Dr. Stinson, obviously, that
was our EP type surgeon, but he had no interest in that. And so as I was in the lab at WashU, Dr. Cox had left, Dr. Damiano wasn't there yet. The lab was being run by a PhD who didn't do surgery, didn't know how to do surgery. So he was leaving it up to the residents that went through the lab to try to get animals through a maze. So he calls me and he says, you know, we're having a little trouble over it. Can you come give me a hand, a surgical hand? I'd never even seen a maze, but I walked in, this is what I saw. The resident had butchered it like a lawnmower went over the atrium. And he said, all we got to do is put it back together. I said, I think we got to find a better way to do this. And that's when when Ralph came and we started working in the lab to try to find the perfect energy source. We didn't want to have to cut the atria apart, put it back together. It was very difficult to do that. And we put a few of these companies out of business, actually, but it came down to the bipolar radio frequency, which Spencer Melby at the time was one of our lab guys and tested how much energy to use, how many times to ablate, and we were able to come up with the protocols to use the RF ablation in order to recreate a surgical line without having to put it back together. And we also studied the atrial function in the maze and followed up on some of the work we'd done in the atrium. So we published our first series of what we ultimately called the Cox Maze 4 procedure. Dr. Damiano and I presented our first 40 patients in JTCVS. And then shortly after I left WashU, he published a near 20-year experience of 863 of the patients that we'd done and showed excellent long-term results in preventing atrial fibrillation without having to cut the atria apart and sew it back together again. So I moved to Texas, and it was there that I got started to get involved in the AATS Foundation, which has put together the Honoring Our Mentors Craig Miller program that we've heard about today. But one of the other things that the AATS Foundation does international educational outreach programs. And I've had the fortunate opportunity to be able to participate in a number of these. But you'll notice, in addition to myself and Dr. Wu, next to us in the pictures are two of my ex-chief residents, Dr. Katchu, who's the aortic surgeon at WashU, and Dr. Anson Lee, who's the maze surgeon here at Stanford. And so that's kind of the kind of thing that Craig always talked about, is watching the people you train become a success. And now these are a couple of his grandchildren in training. So there I was with Dr. Wu and Dr. Lee, and that, you know, having dinner in Thailand was a lot of fun. But probably the most important thing was helping Dr. Lee do a maze. And that's me on the teacher side of the table, and Dr. Lee doing the maze procedure in a brilliant way. Didn't need my help. I was just there to announce. So I wanted to just finish with a couple of words of advice from my mentor, things that I think about this every day, and it's important.
You don't know if you're going to succeed or fail. You'll never know unless you try. And you should do it right, but you can't be afraid to fail. When I was a young college student in the 60s, Haight-Ashbury was the biggest rage. And then I was out there in 68 with Haight-Ashbury, and there was a picture from the Haight of a cherubic child in the woods with the mom, the hippie mom, leading the child into the woods saying, "This is the first day of the rest of your life." And I said, even back very young, that's wacko, that's wrong. Today is the last day of the rest of your life. And if you live it as if it's the last day of the rest of your life, and Lord knows, none of us know how many days we have left on this planet, you will live life to the fullest.
So thank you, Dr. Miller.
We're going to do something special. So before you go off to the break, we're going to take a moment and talk a little bit about Dr. Miller. But before I do that, I want to talk about someone else. Can I hear it? Will that work? Okay. Yeah. You might recognize this guy. So I just want to first recognize Dr. Oyer. Dr. Oyer and Dr. Miller officially retired on the exact same day. And, I told both of them that we wanted to hold celebrations to honor their amazing careers. They both said no way. It's the exact same thing that Bruce Wright and Scott Mitchell said to me 10 years ago. But we kept trying to coax Dr. Oyer into it. And he finally agreed to a retirement celebration for just internal people. And it was in combination with the retirements of Sharon Hunt, John Schroeder, and Mike Fowler. So imagine that, basically a dynasty of transplantation, all retired within a year of each other. And basically 1 year ago, we had a celebration here to honor them. So I just wanted you all who weren't invited to know that you weren't invited because I didn't invite you. You weren't invited because Dr. Oyer didn't invite you. So that day was a very special day because that was the third time in a little over a decade that we actually got Dr. Oyer to come up and say something. I was told that Dr. Oyer never, ever goes to any meetings. He doesn't go to the podium. He doesn't do anything. And we were able to get him to make a comment at the Wrights-Mitchell celebration, which was a very, very special event that all of you thankfully attended. And then for Dr. Shumway's 50th anniversary of his first heart transplant, Dr. Oyer got up there and said some words. And then, of course, last year, Dr. Oyer got up and said some words at his own event. I'm not calling you up to the stage. We already had this discussion. He was afraid I was going to somehow con him into coming up. But instead, I wanted to show you a couple slides from his retirement celebration, just so any of you who weren't here can enjoy the fun that we had last year. So, Dr. Oyer and I have a very special relationship. I get to poke fun at him as much as I do Dr. Miller. And so this is the slide I showed of Dr. Oyer.
I'm going. Huh? It's going.
So I should have prefaced this by saying this is what Dr. Oyer was doing during COVID. He sort of stayed up in the mountains and looked kind of like a mountain man. And I heard the gas heat was shut off, and he had to go out and chop wood and to heat his house. So that really inspired me because when I thought about, what kind of gift you give to someone who has everything. Okay, what do you give as a retirement gift to someone? You give a plaque and you say, thank you very much for your years of service. That's not going to mean something. So this is what we gave Dr. Oyer. Okay. We gave him an actual giant axe, and it has the Stanford logo on there and Philip Oyer, and you can read it says, with gratitude from the Stanford Department of Cardiothoracic Surgery and Division of Cardiovascular Medicine for 51 years of leadership, service, and pioneering discoveries as a kick-axe surgeon. Well, I thought about the same thing. Dr. Miller, a man who has everything, right? He has the love of all of his trainees. He has his llamas. What do you get someone like that? So I found this picture. You've seen this already. And I thought, he's got two weapons there. And I'm glad he's never directed those at me. But I thought, those weapons look a little bit too modern for you. I think you're from a slightly older generation, so I thought maybe we could get something that's a little bit more appropriate for your age. So we have this item. Come on up, Dr. Miller. Go ahead, Dr. Miller. You gotta pull the actually. Okay, here we go. Okay. Let's Gaming at me.
I knew I was old, but I didn't think I was a troglodyte.
So we got a blunderbuss from, I think this is about the 1600s. So
17th century.
yeah, this is about right. Okay, so I'm going to read the inscription and let me put it up
Is
also.
it loaded?
Well, you have all the ammunition in your office. So let's read this inscription, okay? Presented to D. Craig Miller, MD, with gratitude from the Stanford Department of Cardiothoracic Surgery for decades of leadership, service, pioneering discovery, high caliber expertise, and always giving your best shot. Okay, so we're going to start the final session. Last but not least, multi-valve surgery, multi-valve disease, another area that Dr. Miller had tremendous impact on. And we're going to start with Dr. David Yu, graduate trainee of Stanford, and someone who made major contributions at Hopkins and at Yale. He's here now to talk about a new score that he's developed for assessing multi-valve patients.
Well, thank you very much, Joe, and good afternoon, everybody. It's really a pleasure to be here, seeing so many friendly faces, and just wanted to congratulate Joe and the department for truly breathtaking accomplishments since your arrival here, and it is really stunning to see the amazing developments that have occurred in the 24 years since I was here. So thank you again for the invitation. Well, I wanted to talk to you about frailty, which is something that I'm starting to feel more and more relevant to, but specifically frailty assessment and its impact in valvular surgery. Now, the notion of frailty and its impact on cardiac surgical outcomes is not particularly new, but its implementation is still really in its infancy. Ever since Linda Fried at Hopkins formally described the syndrome in 2001, there have been a myriad of definitions, conceptualizations, and over 70 different frailty rating scales, which have made it very difficult for investigators to wrap their arms around a concept as old and as expansive as time itself. What happens when we get old? And so what I wanted to briefly update you on in the next few minutes is current concepts of frailty and how they relate to valvular surgery. So I wanted to go through the modern definition of physical frailty, some misconceptions that many of us have about frailty, the impact of frailty assessments on valvular interventions, and touch briefly on the notion of cognitive frailty, frailty of the mind, and valve surgery. And then finally concluding in the last minute or two on, I wanted to share some reflections that I have of Dr. Miller, who we're honoring today. So the dominant definition of physical frailty has emerged. It is a high-risk clinical state with the patients having it with decreased reserve and high vulnerability to physiologic stressors. It's associated with elevated risk of adverse surgical outcomes, including operative mortality, and is generally thought to progress in a nonlinear fashion toward what has been described as a cacophony of multi-system dysregulation. The most dominant phenotypic frailty rating system is the Fried frailty phenotype, which is used in most cardiac surgical investigations that deal with frailty. And it's comprised of those 5 different elements, any 3 of which constitutes the presence of frailty. Now, the image on the left is a schematic of current evidence and the hierarchical relationships of this evidence with respect to frailty. Here's a pointer. At the top is what we see, the physical frailty phenotype: weakness, weight loss, fatigue, low activity, a slow gait. Underneath it, in these yellow ovals, are 3 major physiological systems with the most accumulated evidence of a relationship to frailty. The orange entities are subsystems within each of these larger systems. Now, in the purple ovals represent stressors from age-related biological changes at the molecular and cellular levels, including cellular senescence, intercellular miscommunication, and mitochondrial dysfunction. All of these serve to dysregulate these overlying systems. The accumulated physiotype of this dysregulation constitutes the underpinnings of what we see in a frail individual. Well, why even bother with frailty assessments? Why test for something we already know? Older people do worse with surgery. And many of us use the eyeball test, age, or even the STS risk calculator to make assessments of perioperative risk in older patients. But none of those entities, none of those modalities is perfect and all have limitations. For example, we all have implicit biases about age, obesity, and other characteristics they may skew our own visual assessments of a patient. We all know that age is not necessarily synonymous with vulnerability to adverse health outcomes. There are really healthy 80-year-olds out there, good 80-year-olds that we are freely operating on and do well. There are some non-visual components of frailty: malnutrition, cognitive and speech impairment, ambulatory ability, sarcopenia, that we may miss in visually evaluating these patients. Now, several population-based studies have identified higher levels of frailty in even younger patients than we once suspected, and that frailty, in fact, permeates all age groups. So frailty is not yet included formally in the STS risk modeling. And why is that? It constitutes an estimated additional 2-fold mortality risk and 5-fold risk of non-home discharge. So why isn't it included? Well, we haven't really defined it very well. There are multiple rating scales, and there's no consensus on how much impact frailty has on cardiac surgical outcomes. But let's see what has been done. So there was a recent study conducted at McGill called the Frailty AVR study, in which the investigators compared the leading 7 frailty scales amongst older adults with a median age of 82 years, undergoing TAVR or SAVR across 14 centers over a 4-year span. They found that one of these scales emerged, called the Essential Frailty Toolset, as the strongest predictor of both 30-day and 1-year mortality for TAVR or SAVR, and that these scores were in fact also the strongest predictor of worsening disability at 1 year. This is the EFT toolset schematic. It's comprised of 4 different elements: a physical task, getting up from a chair 5 times in 15 seconds, which I must say it's hard for me to do, actually. Measures of cognitive function, hemoglobin, and albumin. Each one of these is ascribed a point value. You total them up and you get a EFT score, with 0 being the least frail, 5 being the most frail. And you can see that these scores correlate with an increasing level of 1-year frequency of 1-year mortality for both TAVR and SAVR. And in fact, this scoring system contributed the greatest incremental predictive value to the STS risk calculator. Well, can these frailty scales help us pick the type of procedure that's best for a frail patient, particularly amongst older, low, and intermediate risk patients between TAVR and SAVR? So another study done at Mid-America Heart Institute predictably found that increasing frailty markers were associated with worse 2-year mortality rates and greater health status impairment amongst those patients. But it wasn't sensitive enough to help differentiate a treatment effect between SAVR and TAVR. So these 2 panels compare the 2-year mortality rates and health status impairment between TAVR and SAVR, stratified according to patients with increasing levels of frailty. And although they portend worse outcomes with increasing frailty, there was no appreciable difference, save for a very small survival benefit in pre-frail patients and early health status benefit in the first month for TAVR. So again, not quite resolute enough to help make us a meaningful decision. What about mitral valve interventions? The impact of frailty on outcomes after mitral interventions is much less clear, probably due to the physiological heterogeneity in that patient population. And so without a TAVR-like focus, mitral interventions heretofore have been underrepresented in frailty analyses. But what do we know? So retrospective multivariate database analysis at Penn using the Johns Hopkins criteria for frailty identified a 7.9% prevalence of frailty in that patient cohort. Frailty was identified as the strongest independent predictor of postoperative complications, non-home discharge, early readmission, hospital length of stay, and hospitalization cost after surgical mitral valve replacement. What about catheter-based interventions on the mitral valve? At University of Oklahoma, a retrospective database analysis of transcatheter mitral replacement patients identified a frailty prevalence of 13%, but also frailty was associated with higher odds of complications associated with the procedure. And that goes for the MitraClip as well. At the University of Cologne, a prospective study of 213 consecutive MitraClip patients identified a predictably higher prevalence of frailty in that patient cohort, but also with worse outcomes and hospitalization rates amongst those patients. Well, lastly, I wanted to talk briefly about cognitive frailty as opposed to physical frailty. Now, Linda Fried has advanced that analyzing cognitive and physical frailty together would be a mistake because you could miss some meaningful differences. Nevertheless, I did look with some colleagues, my former colleagues at Yale, at the best available studies looking at cognitive function before and after AVR, surgical AVR, MVR, and multivalvular operations. This schematic basically summarizes the results, the y-axis being changes in cognitive function for good and for bad, and along the x-axis, different time points, baseline at 1 month after the operation and at between 2 and 6 months after the operation. As you can see, all the groups, AVR, MVR, or combined valvular patients experienced an early cognitive decline during the first month after their operation and demonstrated an incomplete recovery slowly over the ensuing 2 to 6 months. We also found that AVR patients experienced a greater degree of cognitive decline than mitral patients, but these patients were over almost a decade older. So it begs the question, is frailty associated with older age yet another contributing factor to the other putative factors for cognitive decline after valvular surgery, including embolic phenomenon, cerebral hyperperfusion, the impact of cardiopulmonary bypass, and neuroinflammation? And that remains to be seen, and something that I'm collaborating with another hospital, another institution on. So in summary, physical frailty is a high-risk clinical state with decreased reserve and high vulnerability to stressors through a dysregulation of physiological systems associated with adverse surgical outcomes. The clinical progression of frailty is likely nonlinear and not strictly age-related. Measures of both physical and cognitive frailty and their impact on cardiac valvular interventions are coming into focus, driven in part by the evolution of catheter-based heart alternatives. And lastly, physical frailty is a powerful prognostic factor that cuts across both surgical and catheter-based valvular interventions. The goal is to incorporate these frailty assessments with current gold standard STS risk models to better improve their predictive power and provide some opportunities for optimization. That is the ultimate goal. Well, I wanted to take this last minute to express my appreciation to Dr. Miller. After Joe invited me to speak today, I spent weeks searching for just the right words that I could deliver in a minute to adequately pay tribute to the panoramic career of Dr. Miller without seeming sycophantic, which I know he has no tolerance for from personal experience. As I struggled, I asked myself why. Why was it so difficult to capture the essence of DCM? And then through the fog of my own cognitive frailty, I remembered he always kept me off balance. I never knew what he would do or say next. He would scrub in and ask me if I understood the stepwise linear regression models of his last mitral paper. And then without missing a beat, say, David, I thought all your people were Buddhist. I mean, I just kind of just looked down and just operated as best I could. He would educate me on the elegance of alpacas, but then also introduce me to elk jerky. He once asked me if I was having a stroke during a moment of technical ineptitude, but then cared enough to actually offer to take call for me in a bunker when I was really sick, which I couldn't even imagine happening. And finally, he was kind enough to invite me and my fiance to our first and last rodeo date at the Cow Palace. But then when he found out that I had a stalker, told me he could refer me to a hitman that he knew who could just take care of it. So how do you characterize that, like in a couple sentences? So I was about to give up when I reached into my drawer and I pulled out this buck knife. This buck knife he gave me on my last day at Stanford. He said, you know, you'll need this in Baltimore. And then I realized that this gift really is the essence of DCM, an American classic, rugged, indomitable, essential, and a little bit dangerous. So thank you, Dr. Miller, for teaching me not only the how, but the why, for espousing surgical education as a privilege and scientific rigor as a duty. You embody what makes Stanford such a great place, a Camelot for cardiac surgical education the technical excellence is infused with humility, civility, and a calmness even in the presence of chaos. You and your colleagues trusted us, your residents, which only inspired us to act and be professionals, no matter where our roads took us. Your contrarian style forced us to question our beliefs. But I'm just convinced that it was your way of helping us believe in ourselves. So I thank you, my family thanks you, and my people thank you.
We're going to have Carol Chen, one of our recent graduates, come up and speak on aortomitral commando.
Thank you for having me here today. I had the privilege, along with my co-fellow, Josh Chan, back over there, to be the last class of chief residents that had the privilege of operating with Dr. Miller. It was probably a situation that Dr. Miller never thought would have happened when he first started at Stanford in the 1970s, to find a very pregnant chief resident standing across the OR table from him. To his credit, he never batted an eye. He treated me like any of the guys, and we got along just fine. So today I've been tasked with discussing the aortomitral commando, which surprisingly, Dr. Miller had no comments on. Endocarditis with aortic root abscess, extending into the aortomitral curtain, is the most common indication for a commando. And this disease is very relevant to us in cardiac surgery because antibiotics alone really are inadequate for treatment of this. And successful treatment of this condition really hinges on surgical removal of all the infected tissues, as well as the ability to reconstruct the very complex anatomy that remains. The first description of this procedure was made by Dr. Manoogian back in 1979. He published a paper on a young patient with congenital aortic stenosis. The patient had an annular diameter about 15 millimeters, so he had to widen the aortic root. And so he did a Manoogian procedure and put in a 23 millimeter tilting disc valve. And the patient did fine initially, and then 4 days later developed severe MR. When he was taken back to the OR, Dr. Manoogian found that the pericardial patch that he put into the anterior mitral leaflet had actually torn off. So instead of repairing the valve again, he elected to replace the mitral valve and trim the pericardial patch, which he sewed to the valve. And that was the first reported commando procedure. A couple years later, Tyrone David in Toronto published a series of 43 patients who had a concomitant aortic and mitral valve replacement, as well as reconstruction of the aortomitral curtain. In his 43 patients, the operative mortality was about 16%, and survival at 6 years is about 56%. So as this field has evolved, the indications for the commando procedure has broadened. The most common indication is still aortic root abscess in endocarditis, which is really also fueled by the IV drug use epidemic, as well as antibiotic resistance patterns across the country. But in addition to infection, there's also non-endocarditis indications. Commandos can be useful for concomitant aortic and mitral valve replacement in patients with severe mitral annular calcification, or previous surgery, or the need for upsizing both the aortic and mitral valves. And I think that we'll probably also see more post-TAVR patients who require commando procedures. Approximately 10% of post-TAVR reoperations are due to endocarditis, and up to 44% of those are associated with some annular complications. And as we heard earlier in the day, removing the TAVR procedure is really no small feat, and oftentimes the aortic root itself needs to be replaced. In addition, a lot of TAVR patients, because of their increased age, have uncorrected mitral disease pre-existent, which may later need to be addressed during reoperation. Presence of MAC is about 50% in this cohort. So in addition to separately replacing these valves, there may be so much damage from the TAVR itself and the MAC that the reconstruction of the aortomitral curtain is necessary. I wanted to show a few interesting cases that have been performed here at Stanford over the past few years. This one is a case report written by Stefan Elde, one of our residents. This is a patient who had a root, ascending, and hemiarch replacement for endocarditis and concurrent type A dissection. And he was discharged, did fine, and 4 months later, he was readmitted with endocarditis, severe AI, moderate MR, and a pseudoaneurysm at the aortic root. The aortic root was dehisced at the underneath the right coronary button and over on the non-coronary cusp. There was also disintegration of the aortomitral curtain and dehiscence of the anterior mitral leaflet. After removal of the infected tissues, a new mitral valve was positioned, and you can see the two struts here of the mitral valve. The left atrium was pulled over to the sewing ring of the mitral valve, and the new aortic valve was seated here where the black dotted lines are. So the two valves here are essentially hinged together, and there was no intervening pericardial patch that was necessary for this commando procedure. So this was termed the modified commando procedure. This next case, written by Kelly Higa, is a 29-year-old man with bicuspid aortic valve who presented 10 years ago with aortic and mitral valve endocarditis, aortic root abscess, and destruction of the aortomitral curtain. So at that time, he already had a modified commando procedure, did well, and was eventually lost to follow-up. Earlier this year, he represented with progressive dyspnea and was found to have severe intra and perivalvular regurgitation and underwent an urgent redo commando. So here is a view down the aortic root, the aortic valve, and the mitral valve underneath that. After removal of the aortic valve, the mitral valve dehiscence was obvious. It's a little hard to see in these small pictures, but over here. The mitral valve was replaced, and there we go. And the remnant left atrial dome was pulled over to the mitral valve. And then the stitches to create the neo-aortic root were placed from the right to left fibrous trigon, or the what would have been the fibrous trigon on the mitral valve sewing ring. And then the homograph that was used here was seated there. This is last case is written by Gabe. This last case is a 42-year-old woman who had a bioprosthetic AVR for endocarditis 7 months prior. She represented with a dilated aortic root, severe MR, TR, and AI with dehiscence of the aortic valve prosthesis. There was also a large perforation from the LVOT into the right atrium. The aortomitral curtain was involved, but the remainder of the anterior leaflet of the mitral valve was spared. So this was prepared with a homograph. Here, the homograph anterior leaflet of the mitral valve was anastomosed to the patient's remnant anterior mitral leaflet. Then a Medtronic CG ring was placed, and then the homograph was seated on the aortic root. Finally, the left atrial dome defect was repaired with extra tissue from the homograph. So I want to end by saying that it's been such a privilege to have learned from Dr. Miller and to have been to have participated in this last era of old Stanford. And it was such an honor to be part of the Stanford family. Thank you.
So we're going to have another graduate, Fred Tabayan, speak about valve reconstruction during LVAD implantation. We thought we'd get Fred to sort of combine a lot of this Stanford expertise into one talk.
I don't think I've been this nervous since the first time I presented sheep data in the fishbowl. This is really a special and humbling group that's come together to honor you and your legacy, and I wouldn't have missed it for the world. Valve reconstruction during LVAD implantation is a really challenging and evolving topic. As we in this room know that since 1984, LVADs really transformed the treatment landscape of patients with end-stage heart failure. And valve disease is very common in this population, but the issue is that we don't have a good idea of if, when, or how to fix it. Spoiler alert, I don't have any of the answers to that. Dr. Miller, of the many lessons I've learned from you, this is probably one of the most important and very relevant to this topic. Now, this quote as it reads is incomplete, as a few people know, particularly probably Mark Moon. And a lot of surgeons might have said this. It's almost not controversial enough to be classic vintage DCM, but if you include the rest, well, there you go. So when you're planning to do an LVAD, probably the first aortic valve, specifically looking for aortic insufficiency, because that gives you circular flow. The blood goes from the outflow graft back into the LV, then back into the pump. And this reduces your forward cardiac output, the unloading and the remodeling. And so even mild AI is associated with RV failure, risk of rehospitalization, and decreased survival. So if you got a patient with significant AI, you've got a few options, but each comes with a downside, right? You could leave it alone if you don't think it's that bad, but it does tend to get worse over time. Valve replacement buys you a cross clamp that you would really rather avoid and increases your risk of thromboembolic complications. Central coaptation or park stitch is a lot faster than valve replacement, but it leaves you almost completely dependent on the pump, which if it fails, your patient doesn't have a backup. So sometimes you got to get a little creative. This is a fellow we met a few weeks ago that presented with cardiogenic shock and non-ischemic cardiomyopathy. He also had severe AI after a TAVR for bicuspid aortic valve stenosis. His right coronary was super low, and so there was a worry that he'd have obstruction if we just did a staged valve-in-valve TAVR followed by LVAD implant. So we took him to the OR, made a small aortotomy, and with the help of a little scope, inspected the leaflets and figured out where the coronaries were and resected them. you'll notice if you're very astute that the person actually doing this was standing across from me and is right-handed. His name is Gurian Lance, and he was a medical student with Dr. Miller a few years ago and remains a big fan. And as he was doing this, he did his best impersonation of me, impersonating you, saying, "This operation can't be done left-handed from either side of the table." And so after resecting the left and right leaflets, we were able to place the sapien valve and deploy it without obstructing the coronaries, and made sure that we would have good flow and that it was placed right. Finished up by just implanting the LVAD like usual. He had a nice result and did fine. But what about the mitral valve? The valve that Dr. Miller spent really the better part of his career studying. MR is really common, dysfunctional or ischemic MR, particularly in end-stage heart failure patients, and its presence portends a poor prognosis, particularly in patients that are destination therapy, and they have poor survival. And some studies have suggested that you could get a survival advantage if you do something about the mitral valve. The question is, which of these patients is actually going to need that? Because the reality is most of the time after you turn on the pump, the valve gets better. You get the LV decompresses, and you get this reversal of the septolateral annular dilation and the posterior papillary muscle displacement and the leaflet tethering that Timek and Dr. Miller so eloquently described in this typically easy to understand and simple figure from the lab back in the day. However, a lot of these patients, even after LVAD, are going to have important amounts of MR, and that's associated with pulmonary hypertension, worse RV function, and increased mortality. So maybe you might ought to think about doing a mitral procedure in the patients who are destination therapy with bad RVs, in which case you got a few options, the central theme of which is you want to reduce the surgical stress on the poor RV. The valve can either be replaced or repaired, hopefully without a cross clamp. This particular view is usually not quite this good, but you can do a transapical edge-to-edge repair before you put in the sewing ring and the inflow cannula. There are edge-to-edge techniques that other folks have talked about today. MitraClip's probably the most common, but you can also do a TMVR like this fellow who got an Intrepid shortly after his LVAD. Tricuspid regurgitation, also an important valve lesion in these patients. And if you have significant TR, your risk of being on inotropes longer is increased. Your risk of needing an RVAD or of having a longer ICU stay is also possible. It's debatable, though, which it is, if the TR is a contributor to or simply a marker for crappy RV. And in fact, sometimes making the tricuspid valve more competent worsens the function of the right ventricle. But even so, tricuspid repair is the most common concomitant valve operation at the time of LVAD implant. We tend to not do a lot of these, partly because of papers like this that did not show a difference in outcome in patients that had tricuspid repair or replacement. And importantly, a lot of the patients had recurrent TR on follow-up, which you also see after mitral repair. And again, there's transcatheter options, edge-to-edge, or the stuff like the Evoke replacement system. So sometimes doing valve reconstruction at the time of LVAD implant is a good idea. But in the future, what we're going to need to do is figure out who's going to benefit. And the only way we're going to do that is by following Dr. Miller's example, paying very close attention to the anatomy, like the subvalvular geometry, the physiology of the right ventricle, and thinking about the duration of therapy the patient's going to be on. And also, our interventions are going to have to be faster, less invasive, and more durable. But back to this guy. Today, and I'm sure tonight, we'll be telling lots of stories like how you made us learn ham radio jargon and Morse code and Latin so we could answer your emails that you would send. He really does send these emails at 3 in the morning, you guys all know. And I may tell some stories about how you harped on me about my right hand so much I threatened to punch you with it the next time you did that. But really, I'm never going to forget all the lessons that you taught me, whether it was in the lab or in the operating room or in your office, particularly one conversation that happened actually at 3 in the morning on a Wednesday night about how I could help keep all this crazy stuff in perspective. It's a conversation I'm sure you've forgotten, but I definitely never will. And I'd like to take this opportunity to congratulate and thank you on behalf of some folks that couldn't be here, but definitely wanted to. Will Yarbrough, my co-fellow, Leora Balsam, my co-intern and co-resident general surgery. I thought Frank wasn't going to be here, but I just talked to him in the bathroom, so you can thank him your damn self. And of course, David Li, who passed a couple of years ago. From all of us, thank you for everything.
So our last speaker is Tomas Timek, and we wanted to sort of bring it all around full circle back to translational research, which really was an area that Craig made such impactful differences in care of patients. Tomas, it's really incredible all of the research productivity that you've been able to achieve since leaving Stanford, and particularly in the environment that you're in. It's just a comment about your drive and your ability. So congratulations, and we look forward to hearing more.
Joe, thank you for the privilege of invitation to what I'm sure will be a very memorable event. In Dr. Miller's vocabulary, when you look out here, there's a lot of firepower. And it's really remarkable that you can trace all that firepower to one institution, much less one person. And that's what makes Stanford really special. So I've been tasked to talk about translational research over 35 years in Dr. Miller's lab. So unfortunately, I will not do it justice in 10 minutes, but we'll do the best we can. So before we talk about translational research, we have to talk about the myocardial marker method. And this was born at Stanford in 1970s. And this method was really predicated on these small tantalum markers of different shapes that you could implant in the myocardium and cardiac structures. And then under biplane video fluoroscopy, you could reconstruct their position with sub-millimeter resolution. And there was actually a tool that was developed for implanting these in the myocardium. And here's actually the photo of the first implant. This is 1972, and the name of the surgeon is Severi Mattia. He was from Finland. But this is not a sheep heart or a dog heart. It's a human heart that's about to be implanted. And so this is how this technique was born. Now, when you looked on the postoperative x-rays of these patients, Joe, just like you mentioned, it looked like they were shot with buckshot. Now, when you're a resident in the Miller lab, you really don't think that. You think this. And you think, are you next? Well, it's actually a lot more benign than that. I mean, this is all for the sake of science. And the genius of Dr. Miller was taking this method from a clinical realm into the lab. And this is what it looks like in an experimental animal. You can see this should be playing, but I think the movie's stuck. But you can see all these markers that you can implant on the valve, leaflets, annulus, and reconstruct the geometry, which is very, very powerful. So armed with this technology, there's a generation of Stanford residents that went into the lab and did some good work. So starting with Abe DeAnda and Mark Moon, I think you've seen this before today. They put these markers in dogs and then did various mitral valve replacements with anterior and posterior chordal sparing, or conventional technique, which at that time meant cutting all the cords out. What they found when you looked at the energetics of the heart, with anterior and posterior sparing, the energetics were preserved, but if you took all the cords out, LV function decreased. This was a really powerful paper that really has affected how we do mitral valve replacements today. Next came Julie Glasson and Masashi. They were the first to actually put these markers on intracardiac structures, starting with the mitral annulus in dogs, and then giving these dogs ischemia and ischemic MR, and found that the lateral annulus was dilating significantly. So that was an important finding that really had clinical implications. And so Julie also implanted annuloplasty rings in sheep. There was a controversy in the literature whether rigid or flexible rings better maintain annular motion. And what she really showed that no matter what you put in, and the annulus was frozen. This was really the first study in the Miller lab that used sheep. And from here on, all other studies used sheep. And so our furry friends were no longer just four-legged mammals. They were really the best model of cardiac physiology. Next came Randy Green. He was actually the first one to put markers on leaflets. And he was able to reconstruct leaflet motion during valve closure. And if you put a ring in, be it flexible or semi-rigid, you froze the posterior leaflet. So basically showed what we all can see on echo intraoperatively, but none of us want to see. This was an important model of tachycardia-induced cardiomyopathy that was developed by Paul Dagum. You could pace a sheep for about 2 to 3 weeks at 220 beats per minute, and that yielded biventricular failure and MR. With markers, you could reconstruct the mitral annulus to see how it dilated with functional MR. You could also see how the leaflets changed. And this was really the first study that showed that the mitral leaflets, both posterior and anterior, actually lengthened in cardiomyopathy and may represent an important mechanism that reduces MR. Really, the holy grail of animal models that simulate human disease was developed by Fred Vial. This is ischemic MR, chronic ischemic MR. So Fred implanted markers in sheep, studied them, infarcted them, studied them again at 7 weeks. Really, really hard protocol to complete. I know it gave him a lot of tears. And so this is what he found. Between the animals that did or did not develop MR, there was basically a couple of important changes: lateral displacement of the annulus and the displacement of the posterior papillary muscle away from the anterior annulus and laterally. Now, Frank Langer picked up the ball from here. After doing some more sheep experiments, he developed this ring and string operation, which was basically predicated on reducing the mitral annulus and repositioning the papillary muscle tip. Now, Frank didn't only do this in sheep, but he also did it in patients. So with his colleagues in Bad Homburg, they operated 30 patients with a ring and string technique and 30 with just a ring, and clearly demonstrated better freedom from recurrent MR with the string and ring technique. So far we've been talking only about the mitral valve, but there is a valve that lives next door that's the forgotten valve, or maybe more recently less forgotten, and that's a tricuspid valve. And that's been our focus, and we've developed a model of tricuspid regurgitation through pulmonary artery banding. So you can put a umbilical tape around the main pulmonary artery, cinch it down to kind of the brink of hemodynamic stability. And in about 8 to 12 weeks, you'll have a heart that looks like this. RV dilatation, right atrial dilatation and failure. And if you do an echo, you'll find that there is severe dysfunction in TR. Now, unfortunately, like Joe said, you can't really replicate the marker method outside of Stanford. So you got to do something else. And one alternative, sonomicrometry crystal, which are kind of a poor substitute, but they're the next best thing. So that's what we use in our lab. And so armed with this, we can now shamelessly replicate all the good ideas of Dr. Miller on the right side. This is looking at the tricuspid annular remodeling or regional remodeling in sheep with functional TR. What was surprising here is that we found that there is significant dilatation of the septal annulus. This may have implications for how we repair the valve, since all the rings that we use are partial rings and don't fully support the septal annulus. We also looked at some reparative techniques or papillary muscle approximation. This is in a dilated cardiomyopathy model. And what we found there, that isolated anterior posterior or anterior septal papillary cinching could reduce tricuspid regurgitation, not eliminate it, but reduce it. So that kind of proved the concept of some of these new clinical techniques that are coming forth of papillary muscle approximation for the tricuspid valve. And it also makes us think that we should repair tricuspid regurgitation on more than just the annular level. You need something at the level of the annulus and probably something subvalvular. Now, as we are talking about translational research, we can bring this back to a patient. This is one of our patients. It's a young lady, 38-year-old with history of IV drug abuse and a large ASD that developed a significant functional TR, poor leaflet coaptation. This was not of infective etiology, but because of her history, really didn't want to replace the valve here, if at all possible. So we did a ring and papillary muscle approximation. You can see the RV being immediately smaller and good control of the TR. I think this is the most important slide of my presentation and a fitting way to end. I like to call this Miller Lab Disciples. This is circa 2005. So this is only a cross section. There's a lot more disciples here in the audience today. This has sort of a feeling of the Last Supper, except we're missing the Dartmouth coffee cup here and probably some lamb chops. I think all the people that are in this photos have been mentored, have been taught, have been really inspired, sometimes threatened by Dr. Miller to be better surgeons, better scientists, and in effect, better people. I think I got a little extra cherry on top. I'd like to think of my experience here in the lab, or clinically actually, in the way that Dr. Miller taught me to look at myself in the mirror. Now, let me explain. When you were doing an operation, a tough operation with Dr. Miller, and you weren't using your left hand, once in a while you said, "What is your left hand doing?" And if you weren't picking up on the message, second time you'd say it a little louder, "What is your left hand doing?" And after the third time you'd say, "Look at yourself in the mirror. You look like a doofus." So to this day, when I start the morning and I look in the mirror and I brush my teeth with my right hand, I make damn sure I have something in my left hand.
I want to thank everyone for your contributions to this amazing event to honor Craig Miller. This was a very special day. I've never seen Craig so happy in my time before or now at Stanford. And so thank you very much for honoring Craig today.